sure he's committed. Yeah.
So
I said, I'm with this. Oh, she is.
All right, if could I ask everybody to take your seats, please? We'll start in 2 minutes.
Oh, she did. Well, I think she's got a little.
That's great. I'm so excited.
Those girls.
Thank
So
you.
you like that?
I love it.
Okay.
Thank you. So I'll reach out to you after the meeting. We can talk a little
Okay.
bit more, but that's great.
She'll definitely. He and I are co-presenting on project. And I think it's an opportunity for
do we get to throw anything if we don't agree with?
No one told me to bring my bucket of tomatoes.
Yeah. Got it. I was thinking round table. No. So?
relax.
Yes. Don't pull your chair over like that.
Oh, there's
One of my yes.
there's sand trap.
Something like that. If they don't like what we say, they just eject us. Yeah, something like that.
I don't know if today, but just grab your just part. It's like months, like every day. Wow.
So you were in the trial, right?
Yes.
Are you still on?
Well, I'm in the transition.
Never let up.
So
Yes.
yes. I guess the best way to say it is still getting dark and they're working with insurance. No. In trial though.
Yeah, with that, absolutely.
Oh, right.
It's like affecting us. I'm like, excellent. All right. Thank you for coming back. The CEPAC, we just need to make sure we have all the CEPAC members. We're missing one. So we'll need Brian to come back. So the process again from here is that having had the discussion, obviously evidence and input from manufacturers, patients, there's still a lot to do. As we move into the voting phase, it will kind of crystallize some of the issues around uncertainty, around the benefits and the potential harms. So it's an opportunity for the council to think about those issues again as they prepare to take specific votes. So I've asked to come up to the panel here for this phase so that they're really easily accessible to you. Again, 2 patient representatives who've been already introduced, the 2 clinical experts, and Dr. Rin and Dr. Zimmerman. And Ryan is in the house. That's all right. Okay, so we're first going to have a process of, actually, Sonia, aren't you going to run them through this? Yeah, why don't you run them through this part, because so we're just going to work out the voting technology, and then we'll launch into the meeting. Go ahead.
Sure. So everyone should go to, everyone meaning our panel, should go to responseware.com or to the app. And I've shared the session ID with everyone, but if you don't know the session ID, raise your hand, we'll come and give it to you.
Hold on. What is the internet we're connecting to?
Oh, yep, let me do that. Here's the internet. The Wi-Fi would be, the username is ICER2017, and the password is that set of letters and numbers. I'm gonna hit reset, so if you see that, don't be surprised. And everyone should see the voting question up in front of them, raise your hand if you don't see the voting question, and I will come help.
I'm behind. What is this? Did you have to do username? Well, I'm sorry. What was the password
Sure.
for the internet? I'm a step behind. ICER 2017 was the username.
You're just going to keep getting those triggers and set it off. And so then you just get into the vicious cycle. It's going to almost like a drug addict. Come off, those guys go right back on.
Got it. All right.
You know, our system doesn't even
Maybe
have
go to
education, right, in terms of reimbursement and practice setting. It's a problem. That's some of my patients who have like topics. They're a train wreck. I remember they were
Yeah, okay, so while Ryan's getting up and running, voting question is, what new invention was debuted at the 1893 Chicago World Fair? Your choices are A, unicycle, B, rotary telephone, C, Ferris wheel, and D, frisbee. So we've got 8 responses, we need 3 more.
I don't know.
One more response.
I think you should so they get the voting systems.
You don't see it. Oh, there. Down at the way bottom.
Okay,
Have you voted already?
all right,
I just voted.
great.
Okay.
All right, so we'll see what the responses were, and I'll tell you what the correct answer is. So 55% of you got the correct answer. It was Ferris wheel. All right, I'll hand it back to you, Steve.
Great. Okay. And actually, with each question, I'll let you manage it if we need to, but. All right, so here's the first voting question. There are 6 of them, just so the audience knows. In the patients with mild to moderate atopic dermatitis, is the evidence adequate to demonstrate that the net health benefit of treatment with crisaborole, or crisaborole, is greater than that of treatment with topical corticosteroids or topical calcineurin inhibitors? Now, in your evidence summaries, in your binders for the council, I believe the material on crisaborole starts on page 5. Yeah, page 5. You want to see some of the tables? David, do you want to just give, again, a very brief, high-view summary of what you already presented to them earlier today related to this specific question?
Sure. We have no head-to-head trials and limited evidence from our attempts at doing comparisons, and we rated that we had insufficient evidence to make this comparison, and so we didn't think we had adequate evidence.
Thoughts or questions from the council? Reem?
I think one thing to just highlight again, and David has mentioned this already, is that we really need those head-to-head trials. As a clinician, I'm sure the patient community, because that's such valuable information that we're lacking, and would be important for the companies to consider that.
Ask the clinical expert to comment specifically on this issue. It may not be so germane in a way to the vote per se, but are the patients who will be considered for crisaborole those who would not be, for instance, considered good candidates for topical corticosteroids for whatever reason? So is there any tension in doing that kind of head-to-head trial? And any other comment you'd like to make?
Doing active comparator trials is, of course, very difficult, and there's a lot of controversy and even FDA requirements with regards to which trials get active comparators. I do think for this particular drug that It's doable to have an active comparator. It certainly wouldn't be with topical corticosteroids. It would be with one of the calcineurin inhibitors. And we would like to see that data as well. But, you can't, that's the difficulty, is even the way that these trials are designed aren't really the way that we use these drugs in real world. They're steroid-sparing drugs as opposed to corticosteroids, and they work differently. So that would be the place that you'd want a head-to-head trial. But in moving forward with a drug like dupilumab, you couldn't design a head-to-head trial with an active comparator because we don't have any good data to, to help to guide and design that trial, power it appropriately.
Yeah, I would agree with that. I think in the way the question is worded, it's fairly broad. And so, the first thing we usually would focus on is on the efficacy data. And there, admittedly, we don't have head-to-head, and so it's hard to make that comparison. And I'm glad, actually, that the exercise of sort of modeling it against pimecrolimus wasn't taken, because I think there's so many measurement issues that came up in the differences in trials. But I think the difference here is on the safety side of things, because to Elaine's point, topical steroids can't be used comfortably long-term in patients who require sort of daily consecutive use for weeks at a time. That's by definition where we need those non-steroidal agents. So it's an apples to oranges comparison. Now, the topical calcineurin inhibitors are in that class, but then you start getting into this issue of the black box warning. And so, now on a safety level, you're talking about a completely different, beast in that sense, and a much better, cleaner safety profile. Yes, this is still controversial, I think, about this whole malignancy signal, and the 10-year post-marketing registries to date for both the pimecrolimus and tacrolimus have not shown anything, but it's very early to actually pick up a cancer signal. And there's actually now some emerging data that really says it is a real signal, which I don't even want to know what we're going to have to deal with patients once that hits the light of day. So I think you're talking about potentially safer option, with the caveat that it's early, and yes, you find it 30% of the time after phase 3. But I think this as a class is going to be a safe medication overall. And so now you're weighing the pros and cons of a safe medication that may or may not be as effective versus medications that have demonstrated efficacy over the years but really have some challenges in their safety profile. And so when you think of that net benefit, I think that's the challenge here. How do you answer that question?
And the medical legal repercussions of that black box were unbelievable, including even in our long-term trials, there was a 50% dropout rate in the patients who were in this prospective long-term trial just when the black box came out.
Okay.
So,
At what point did the black box warning, or did the signal come out for topical LDL and protopic?
So there really was no signal. I mean, this was a theoretical black box warning. It was hit in 2006.
Unprecedented.
Yeah, and this is in the peer review literature. So what I'm saying, so as much as it sounds controversial, it's in print, it's in the literature, that this was really the FDA's response to off-label marketing, particularly for one of the two. And so it was a theoretical black box warning in the idea that if you gave whopping doses orally, that you would get potential malignancy signals. It was never originally demonstrated for the topical calcineurin inhibitors.
And hasn't been shown since.
Right. So the FDA mandated that both companies, now it's been passed on to other CROs and other companies, but both companies have these 10-year post-marketing registries. And to date, nothing has emerged. The problem is that for some of the studies, you don't even have close to 10 years of observation period for the patients. There's very high dropout rates. So we reassure patients with those data, and we hope that it's true. But if longer-term data come to light that this is real, and without saying more than this, I've seen such data around, it just hasn't been published yet, it changes the whole conversation. And I know we're left making this decision right now on how to sort of think about the landscape, but that's a real safety concern. And even if it's not a real safety concern, right, even if it turns out that it's not there, when a patient goes to the pharmacy and the pharmacist says, this has a black box warning, you're going to get cancer from this. That's it. It's over. They're not going to use it. And so they fill the prescription. It's a fortune. We get the prior authorization. We do everything. And then they've used it once or twice, and they're done with it. So the compliance issues that come up, the long-term real-world effectiveness is really challenged by these safety concerns, and that's certainly true for the topical steroids, where they're used lower quantities than they should, shorter periods of time. And because of that, we're always left with this frustration. And in truth, some of these patients end up going on systemic agents when they could have been better managed topically, but all these safety concerns come up.
Thank you.
All right. Yes, Harold.
That all sounds very compelling, but it's such a strong argument for doing the randomized trial that would allow us, I mean, I'm listening to you with some, yeah, I'm learning a lot from you. It's frustrating to listen to the insights that you're providing because I so want to say yes to this for all the reasons you're saying, but what you're saying is the argument for getting the data that would establish what you're saying. And you know, it's just we need to have a trial that demonstrates greater effectiveness. You know, so
You know, I completely agree with you, but that kind of a trial, I can't even, it's hard to begin to know how to design it. You know, with a single drug, it'd have to be a 2-drug trial, and it would have to last a decade or more. And, you know, it would cost billions of dollars. I don't know how to reconcile those things.
No,
All right, I want to try to keep the conversation going, because some of these issues around future research we'll return to in the policy roundtable. So we're going to try and focus in on the evidence that is before us for this vote right now. Mary?
I think this was alluded to, and I just, I don't have an idea. I got an idea of tacrolimus, and, but the cost, was that left out intentionally of what this is costing patients or payers?
Well, cost is not relevant for these votes on adequacy of evidence for comparative clinical effectiveness, and I actually don't know what the current price is. We can return to that perhaps on the roundtable.
It's comparable to the drugs that are on the market now.
Scott?
How do you interpret a trial that's 4 weeks in duration? Could you educate us on that? You talk about the long-term safety concerns. We have a 10% margin here in terms of efficacy with IgA. Can you elaborate and educate us on that? 4 weeks to me seems an inadequate amount of time, but how about from a practical clinical standpoint?
You know, so 4 weeks was enough to tell you, you know, they hit a certain effectiveness or efficacy endpoint. The beauty of the nonsteroidals is that you can keep them on it longer. You don't have to pull the plug sooner. Like with a topical steroid, 28-day trial is actually standard because you're not really comfortable with them using it more than that. And so, sure, it'd be nicer to see longer-term data. There was a study done, I think, that went up to 48 weeks. I don't think it made it into the report because it wasn't yet available, that shows longer-term safety and efficacy, and it's pretty comparable. Sure, I would love it if you had a year of data. I'd love it if there was a head-to-head. I love all these things. I think
We also have efficacy on a systemic agent that works by the same mechanism of action with that, you know. So we don't have great efficacy data. We just, and the trials weren't designed in the best way, you know, from our perspective about giving you confident data. But given everything else that we know about the mechanism of action and the disease and the age group and the systemic exposure from another similar drug, that's what makes us feel comfortable with it.
And I, you know, this is, I don't want to beat on this point because we can talk about it in much more depth later, but when you get into some of the measurement issues of like the problems of this IgA score, you know, an IgA score only takes one thing into account. It's a representative lesion and looks at how severe it is. And so these patients were all labeled mild to moderate in the crisaborole studies. But when you look at the baseline characteristics, you had patients with up to 95% body surface area, which you know that if we would have assessed them by this eczema area and severity index, they would have been moderate to severe, and yet still they improved. So I know it's hard to assess the evidence, but if those patients had that level of surface area and got better, these are actually arguably more in the moderate spectrum and really not so mild at all. And that puts context into it. Now, it's still not head-to-head, and I know, and this is the gap, but I think that it's very hard to interpret IgA as a solo endpoint, and yes, I would love to see more data.
All right, Ryan.
Could you, the clinical experts, could you speak to, so dupilumab is not approved for children, is that correct? So can you talk about, specifically about children and crisaborole as an option? I'm just trying to understand more about, so dupilumab is showing some really effective, but we're not talking about kids that are affected by this. So I don't know. I don't know if I have a question as more as, do you have a commentary on that?
Right, actually, let's bring that up in the policy roundtable, because I had intended to ask that question as it applies to kind of how we apply the evidence to certain patient population groups like that. It's a very good question. All right, any other questions about the evidence related to this vote? All right, then please, some of you have already started to respond. We know that there are 11 votes, so once we get there, we will be able to tally it. All right. Sonia, does it pop up by itself, or do I need to click? There we go. All right. So unfortunately, we're kind of blocked in seeing it, but I will see if I can move that. There we go. All right, so the votes are, of course, we can do algebraic math quickly. 82% of 11 votes. I assume that's 9 votes. 9 no, 2 yes. All right, so we'll go to the next question. The next question is about dupilumab. In adults with moderate to severe atopic dermatitis who have failed topical therapy, is the evidence adequate to demonstrate that treatment with dupilumab provides additional net health benefits beyond continued non-pharmacologic treatments such as emollients? Yes or no? David, again, do you want to summarize briefly the available evidence? This is on pages, the tables at least are on pages, starting on page 3 and 4 of your evidence summary.
Sure. So this is really the direct question asked in the randomized trials. We see better than 3 times relative risk of achieving specific outcomes of improvement with dupilumab versus the comparator of placebo in that setting, which is like continuing the emollients, which is what's going on with them. You could question on the safety side, given the concerns about long-term safety, what we do or do not know. I think that becomes a bigger issue later. Here, it's obvious how much greater on the benefit side it is, and so you could imagine what degree of harm that we don't know about would have to be. That difference would have been the difference between our rating this as superior, which we didn't rate it, as opposed to incremental or better, recognizing that it might be superior, or if there are harms we don't know about, it might only be incremental. That's how we put the evidence together.
All right. Questions from the council? I see that 7 of you have felt quite confident in your vote on this question, since the votes started coming in before I was done reading the question. Any questions? All right. Don, go ahead.
Yeah, I just want to put a placeholder in this for the roundtable around how we're viewing net health benefits in the context of what seem to be imprecise, roughly speaking, imprecise measurements of health benefits from a biometric standpoint as well as from a patient-reported outcome standpoint.
Okay.
Well, I would just, very quickly, I would add, for this trial, there are a lot more data points. 21 in a hierarchical analysis that even though each one doesn't ever tell the whole story, all of them very highly significant, robust effect sizes. So we can talk about all the measurement issues, but this is not just an IGA story. You have EASI, you have SCORAD, you have DLQ, you have a ton of other measurements there. So.
Right. So this was one where there were a variety of different measures, none of which I think by themselves were viewed as perfect, but as he said, they all aligned with a pretty clear picture. All right, we need all votes in. We have all votes in. All right. I can figure out what 100% of 11 is. 11 yes and 0 no. All right, moving on. In adults, same patient group, adults with moderate to severe atopic dermatitis who have failed topical therapy, is the evidence adequate to demonstrate that the net health benefit of treatment with dupilumab is greater than that of treatment with cyclosporin? Again, I'll turn to Dr. Rin to summarize briefly the evidence on which this vote is based.
Here you saw the relatively small amounts of evidence we had on efficacy of cyclosporin, suggesting that on an order of magnitude view of the world, its efficacy might be similar to that of dupilumab. On the harm side, we are quite certain about the harms of cyclosporin, and they are real. And we have uncertainty about the harm side with dupilumab, as we talked about. We ended up rating this equivalent or better, recognizing that better could be all the way up to superior, but we felt like we were unsure. That said, I could imagine disagreements about how one might compare cyclosporin and dupilumab, particularly given how you would guess that clinicians and patients will vote with their feet on this one.
Before I even let the clinical experts, who I know will have a comment here, and perhaps the patient representatives as well, first, any questions from the panel about the studies, about comparativeness, if you will, of the patients? The evidence is at the bottom of page 4 of your evidence summary, if you're looking for the table. Reem?
Really a question from a practice point of view. Now that this drug is available, will you ever use cyclosporin? Are there a group of patients that you think?
That's a perfect question for the policy roundtable. Okay. I know it's hard not to go on that fast track. And also, let me invite a comment from the clinical experts about the evidence and how you think clinical experts view the evidence. And if the patients have a comment as well, I'd be happy to hear it.
The evidence, I think it's clear cut about the evidence, especially the safety part of it, and if we wanted to talk about, will I ever write for cyclosporin, we left out of the report was the other immunosuppressants that we use, which are, maybe safer, but hard to say, and I don't know that I'll write for any of them again, but the biggest elephant in the room is how much it's all going to cost and are you going to be able to get it. But the other thing about these immunosuppressants, besides just the data that points to the safety issues, these people have to get, when you're on cyclosporin, you have to get blood tests every month, and if you don't get your blood tests, you can't get your drug, and then you have a gap in your treatment. And there's a lot of complexities, that you have to do for safety monitoring as well, so other costs.
I would just say, the benefits from an efficacy standpoint from cyclosporin really are not borne out in the data. They're borne out from anecdotal experience from KOLs who play with it. There's, to my knowledge, only about 3 RCTs that have been done with a total number of subjects of about 100 people, maybe 150, who've actually been treated in a randomized controlled trial setting. That really doesn't amount much to evidence. With a range of efficacy, if I recall correctly, somewhere in one trial as low as 25%, another trial about 90-something%. Variable dosing regimen. So from an efficacy standpoint, it's really hard to call that evidence of efficacy in cyclosporin.
Open label, by the way, open label treatment.
Yes,
Yeah.
right. So now you have the only drug that's been studied in, I think it's over 2,000 subjects with atopic dermatitis, multiple trials, phase 2, phase 3, you have long-term data. For cyclosporin, no study went beyond, I think, 3 months. So here you have up to 1 year of data. I mean, there's just no comparison in terms of the quality of data. Even amongst the 3 studies for cyclosporin, you have disparate endpoints, untrained investigators. I mean, I don't even know how, I'm not even talking about safety now. We're just talking about an efficacy. The level of evidence is just so much greater for dupilumab, but just from the sheer number of subjects studied than cyclosporin. Then from the efficacy standpoint, or from the safety standpoint, we don't have any long-term safety data for cyclosporin in the context of atopic dermatitis. One might argue this could be a younger, healthier population, so maybe they could tolerate it a little bit better. But the reality is we know what the harms of cyclosporin are. Yes, there's always uncertainty with any new drug, so dupilumab we don't know. But it's something that the FDA's mandate or suggestion is we should never go beyond a year. And when you look at the drug survival studies for cyclosporin in atopic dermatitis, 75% of patients couldn't get beyond, I think, 3 to 6 months. So there may be a subset of patients who we can use cyclosporin in if you thought they had more intermittent episodic disease, but for these chronic patients, to me, it's a no-brainer both on the safety and the efficacy.
David, you want to follow on that or not?
This is the discussion I certainly expected would happen. I think the experience of many clinicians with new exciting drugs in specialties where new drugs come along a lot is to have learned over time that it's not a theoretical idea that unexpected safety things show up. And so the way we put that together in the report was to let all of you know that that's a real worry, that we don't want to claim certainty that isn't there. That doesn't mean that a sensible clinician or a sensible patient right now might have a very clear choice that they would make, but we'll be a lot more certain 5 years from now than we are now.
Great.
Steve, just to follow up, and this really applies to question 2 as well. I'm voting with the notion that...
Can you pull the mic just a little bit closer?
I'm voting with the notion that we're talking about short-term net health benefit because of those unknowns with these medications.
I think the way that I would encourage you to think of this is that for a decision made today, and a lot of these questions are looked at as we'll talk about in the policy roundtable, as applicable to decisions around clinical decisions, but also for decisions around coverage decisions. So given the evidence we have today, which is always imperfect, but it does make you make a judgment that will always have you trying to consider the longer term and to the degree that you feel confidence in your knowledge of that net health benefit. So I'm not making it any easier for you, not at all.
I can add one more opinion about that. This is a heterogeneous disease, as we've discussed, but there's a subset, especially the people who have moderate to severe disease, that probably have under-recognized primary immune deficiency. There are all kinds of examples that I could give you to support that. But if you use drugs like cyclosporin or prednisone, for example, it's something that has the potential, I think, to potentiate that disease and also put people at risk for other kinds of infections that we know that they already get, overwhelming strep, recurrent herpes, sepsis, furuncles, all that kind of thing. And that a drug like dupilumab, it's just, by its mechanism of action as well as the one-year trials, it doesn't do that. And the trials didn't exclude people who had those kind of infections. They were all included in that trial, so I think that's important to know.
And dupilumab is the first drug with its mechanism of action in the market. So we don't have any other experience with a similar mechanism of action in longer-term studies. Okay. All right. I also want to encourage the council not to vote until all the discussion actually is held, because sometimes you'll find that the comments or the questions raised will actually make you reconsider your vote, and you can't go back and change your vote in our system, right? You can change it. Oh, okay. So apologies. So you can. All right. So I see 11 responses. Any other questions, or people want to change their vote, or should I click on the? Okay. So we have, again, how come 91? Okay, 91% has got to be 10 people, right? 10 and 1. All right. We often try to capture in our final report a brief description if there's a distinction in votes behind the rationale. The one person who voted no doesn't have to self-identify, but if you'd like to, just to explain to us your reasoning.
That was me.
Okay,
I just
Scott?
thought the comparative evidence was one that wasn't adequate.
On the basis of just, well, there's no
Head-to-head
trials.
trial, yeah, what I wrote down, head-to-head trials. Lack of willingness to prescribe the other one, really, in the clinical standpoint. So making that comparison, to me, from an evidence standpoint, there really is no reason to do it.
All right. Okay. Let's keep going. All right, we're ready to move into the value votes. And as you know, we only did a cost-effectiveness model on dupilumab. So the votes will be on that, and we have 3 votes, one on the entire population according to the label, and then we will have a vote separately on moderate to severe, and we'll have, I'm sure, a discussion about that. So let me read it. Given the available evidence on comparative clinical effectiveness and incremental cost effectiveness, and considering other benefits, disadvantages, and contextual considerations in a mixed population of adults with moderate to severe atopic dermatitis who have failed topical therapy, what is the long-term value for money of dupilumab compared with no systemic treatment? Choices are low, intermediate, and high. And Marita, I'll give you the chance this time if you want to briefly, you may not have it in front of you, but you may remember it, but do you want to give a very brief summary of the findings of the modeling that you think is germane to this question?
Sure. So we just the overview of the results, we found that there is health gains, as we talked about, for dupilumab of around 2 QALYs, a little less than 2 QALYs over the remaining lifetime of the patient, with increased drug costs, but there is some cost offset because the underlying costs decrease for patients treated with dupilumab. And that led to an ICER of about $124,000, I think, using the list price of dupilumab of $37,000, and $101,000 per QALY using the net price of $31,000.
All right. So, and then I think we've heard, again, it's in the report, but also testimony about the potential other benefits and the contextual considerations for this treatment. So we want you to also consider that, discuss it further if you'd like. Any questions? Yes, Don.
So I was going to ask in your presentation, Marita, but I'll ask now if you could give for dummies like me, a 2-sentence explanation of the disutility index that you presented.
Sure. A utility value is a measure of quality of life on a scale from 0 to 1, 0 being death and 1 being full health or perfect health, however you want to define that. There's a lot of different ways to measure it, a lot of different scales that are used. In our case, it was measured using the EQ5D, which is a measurement of overall quality of life related to health. It's not specific to atopic dermatitis. Yeah.
And so the low value, help me with the low value. It was
Yes.
0 something.
Yeah, for severe patients at baseline, it was about 0.53, I think, and moderate patients were just above 0.6. So if you think about where that would be, 0.5 is halfway to death, halfway between full health and death. So if that gives you any reference, I mean, these are patient responses that are giving this, so it's kind of a reflection of how they're feeling about health overall.
Okay, thank you.
Great.
I want to just go back to a point that Harold mentioned earlier and just again highlight those are really, from a clinician point of view, pretty low utility ratings. And I did hear from the experts that they see lower than that. But I also want to highlight something that David mentioned is those patients were sicker than the inclusion criteria in the trial. And I think this really has to be very, very clear. We're dealing with a sick group of patients and with all the issues around heterogeneity in the condition, but also in how we measure moderate and moderate to severe and severe. Those are sick group of patients, and those utility ratings are low, just to keep that in mind.
Okay.
And sorry, the
No, go
utility
ahead.
ratings were a big drive in your model. They
Yes.
were the main drive.
Yes.
Rachel.
Related to that, I wanted to ask, because Dr. Silverberg, you weighed in
Sorry,
on
can you
this.
pull the microphone?
Oh, sure. You weighed in on this, excuse me, in response to Harold's question, but I'm wondering if you could talk about the severity of the patients enrolled in the trial as compared to the severity of patients that you tend to see and/or patients you think you'd likely to be prescribing this for.
So I was an investigator in the phase 2 and the phase 3. My patients were I put them into the study. These were, they met all the definitions. It was a range. Some of them were on the high end of the moderate spectrum rather than being the absolute worst of the worst. But they all had the inadequate response to topical therapy. Most of them we had already tried systemic therapy. It's a side point, but when you talk about like comparing it against cyclosporin, even the patients who do amazing on cyclosporin, the party has to come to an end eventually, and they're going to have to switch over. So it's just kicking the can down the road. It's not really doing anything clinically for long-term treatment. But anyway, so many of these patients were on systemics previously. and washed out, flared up, ended up going into the trial. And it was life-altering for them. Not every patient, even some of those who technically were treatment non-responders, it was the first time they had a job in 20 years, first time they had a relationship. I mean, you can't, I mean, I know you're thinking these are the sickest patients in the world. These are actually not some of my sickest who went into the trial. The sickest couldn't handle a washout period of topical and systemic agents because then they would have become totally suicidal. So they're not the worst. And that's why I said some of our utility scores are even lower that we see in the real world.
I wanted to ask a question, and this could be either for Debbie or Meg or John or Elaine, but the base model depends on about a 50-50 split between moderate and severe, so I think it's 53 and 47%. Does that reflect your practice or your experience with other patients, that about half of the people that would be in this category of moderate to severe would be moderate, and half would be severe? Or is it just...
I'm glad you asked that. You know, we've had a lot of debate about, you know, this categorization
Yep.
of moderate to severe, and so our IGA score is static, you know, at that point in time. And I think, you know, at the time that they entered the trial and got that IGA score, it might not reflect, you know, what the natural history of the disease would have been, you know, outside of the trial. So I think that's different too. But I think that it's hard to separate those two things out, and, you know, moderate to severe is sort of the same category. So.
Okay.
Yeah, I think every practice setting is going to be a little bit different in terms of what you're going to see in the real world. This is a very good point that Elaine is raising about, you know, moderate to severe. It's sort of, it's a little bit of a broad range. And, you know, you can have patients who are mild 90% of the year or 95% of the year, but there's like 2 weeks of the year with the change of seasons that they get into a severe flare. That's not the patient who got into the trial.
Right, I get that.
These patients are at baseline moderate to severe, and then they get even worse and very rarely get better. So it's a different sort of class of patient. And, you know, so what I see, most of my patients tend to be on the very high end of the moderate, more in the severe category. Other practices are going to be a little bit different. There's a total referral bias because these are very hard patients to manage. There's so much going on. There's so much complexity with the comorbidities and treating the whole patient that in the average practice setting, it's almost impossible to handle given the limitations of our healthcare system. So, I mean, take it for what it's worth.
Yes, Don.
So for the physicians, do we actually know what the suicide rate is for this population compared to the general population? I mean, you're talking about it, and I understand you're dealing with it, but my question is what's the epidemiology if we know that?
So this is a paper published in the Journal of Investigative Dermatology about a year or change ago. We looked at two cohorts, one from NHANES and one from National Health Interview Survey. For NHANES, 20% of patients, now it's across the entire U.S., who met this empiric definition of atopic dermatitis, met the SIGE-CAPS, you know, clinical criteria for depression, major depressive disorder, with I think it's about 5% of that population having, or maybe a little more than that, moderate to severe depressive symptoms. That's not knowing that the overwhelming majority in the population are going to be mild disease. And so that, you know, just gives you a sense of how common these mental health symptoms are. Looking at a National Health Interview Survey, it's pretty much the same thing. It was 1 in 5, about 20% who were diagnosed and being managed as having depression. So we don't have great numbers in a population setting for moderate to severe. That's true for a number of the epidemiology issues of moderate to severe disease in adulthood. But from the clinical cohorts, and certainly from the dupilumab cohorts, you know, depending on the outcome, you're using the HAD scores or whatever, very, very high rates of mental health disturbances and suicidality.
Well, so, yeah, but my specific question, knowing that many chronic diseases have a higher rate of depression, is specific to whether you do or do not know what the suicide rate is compared to the general population. I'm speaking specifically of death.
To suicidality. There's one study that looked at a European cohort, I don't know about in the United States, but the rates of suicidality in that study, also published in Journal of Investigative Dermatology, it was a 13-country study, multi-center, showed, I think, an odds ratio of 2 or 3-fold higher odds of suicidality compared to that baseline population, but it's not answering your question directly.
Okay.
There are numbers out there. I don't remember all of them off the top of my head.
Okay. I have one last question that didn't come up in the discussion so far. In addition to talking about the severity as it relates to the utilities, the quality of life, the cost offset, do you think that that cost offset is reflective of a very, very severe population, a more moderate? I mean, since we're trying to grapple with this distinction between moderate and severe, how do you think the way that you estimated the cost offset fits within that discussion of moderate or severe?
Yeah, we did talk about this because we have limited data for those underlying healthcare costs, and our clinicians might be able to have some input too. When we were thinking about this, we pictured this cohort of patients is not a particularly high utilization group, just because there's not a lot of treatment options that are very effective. So they have doctor visits and they have some hospitalizations or ER visits. But overall, when we were trying to picture what could be different between moderate and severe patients in terms of those types of costs, I can't picture a lot of things that we would think would change besides having slightly fewer of those. So I would guess that this should be representative of the average. It's, about half moderate and half severe patients. But we don't know where on that range each one would be.
But the Hassan?
Yes.
But the modeling, and probably, it doesn't take into account under cost offset, I guess it's not really, it is and isn't a cost offset, at least in my head, of if someone could go back to work and contribute to the economy, and that's not included.
Correct. Productivity costs are not in this model. Because we did this from a payer perspective, productivity costs aren't included. We do think that that's important, and we did attempt to do a scenario analysis that included that, but there's just no data.
All right, so I'm very glad you brought that up, because I've been very open in discussion about this. I think that's a major challenge when you're only looking at direct payer costs. This is a disease that costs a fortune of money to the patient right now, because there's a lack of prescription options that are effective. So, you're not going to, here you have a reduction in terms of cost of emollients, out-of-pocket costs in terms of topical steroids and things like that. But productivity and those issues are a major aspect of things that are really left out of the model. And, this is something that I think, it'd be a good idea to hear from the patients from this, but just about how much it has cost them out of pocket. It's a big deal. So I am glad that you brought that up.
And actually, maybe that is a question for the patients, but I would imagine there's a big productivity for the actual patient, but also additional productivity gains for maybe the spouse or loved ones that are losing economic benefit from caring. So I don't know.
And from the healthcare providers. As I say, 50% of my patients, 90% of my time. It's really very time consuming, and of course that takes time away from all the other things that you have to do.
Meg or Debbie, would you like to chime in, or you have anything to add on that?
I don't even know where to start. There's so much to say. Yeah, I mean, it's been huge. I've tried everything. I did the cyclosporin, I did the phototherapy, I did CellCept, I did the wet wraps. I tried everything, and nothing worked. I mean, even cyclosporin, I was on it. My husband's been on cyclosporin on and off because he's a kidney transplant recipient. And so I know how horrible that drug is, and I said I'm going to do it anyway because something's got to help me. Well, it didn't. So when dipilumab came out, I jumped right in. I mean, I didn't have any hesitations at all.
How has it changed your everyday life?
Oh, gosh. Everything. I mean, when I think about my life before dipilumab, the hardest part for me, and there were many hard parts, but it was the showering. The pain that I can't even describe. I mean, I would dread it for 2-3 hours before I knew I had to do it. I had to do it at night because it would literally take my skin about an hour to settle down. I would get out of the shower and be a bright red. You talked about the suicide. I never really considered myself as a very anxious person. I'm very upbeat. I'm a teacher. that in itself is stressful at times, but I really thought I was pretty laid back until I got dupilumab. And 5 days after I got it, I realized what it felt like to be peaceful inside my body. I knew I got the drug. I didn't know if it was a placebo or not, but 5 days later I knew. So the showering was just unbearable.
All right,
And
I'm gonna
I
have to
did-
bring it
I'll
back
just-
then. Great. That's very, I think it's really helpful for the council to think about some of these other benefits, as we would call them, into the consideration, because productivity was not modeled directly into the base case findings. I guess the point briefly that I was thinking to make, and you can tell me if I'm wrong, the way that you estimated the difference in costs between responders and non-responders was based on the cost of patients who were getting phototherapy or cyclosporin for their atopic dermatitis. So that's a pretty severe cut of patients with atopic dermatitis today. So any cost offset is kind of based on that assumption that when you're non-responder, you're having a pretty high cost. True?
True.
Okay. So again, the impact being that I think cost offsets are real. We heard from Susan, I'm sorry I forget her last name, but there are definitely other hospital and other costs that are kind of not just correlated, but caused by atopic dermatitis. But I think the modeling certainly captured that on an average basis and tended, I think, to make sure that it captured the cost offset for the very severe patients. Don?
Well, and I think we still don't know what the decision points are around frequency and dosing targets related to measuring response as precisely as we should, including length of therapy, right?
How so?
Well, maybe it's just not clear to me.
I mean, here you have the outcome measures to justify, so I don't think it's a measurement issue per se. I think if you want to know, like, what is that endpoint you need to get to being productive again, getting back to work, being functional again, there's no public data, to my knowledge, has really looked at that level of clinical meaningfulness, and we've started to look at this and found that probably the best endpoint is EASI 50. Which is not actually what was used in the report, because the FDA looked at EASI 75 and 90, and EASI 50 response rates were about 85 to 90% across the trials. So it gives you a sense about that level of productivity pickup would occur in probably 90% of that population.
I'm thinking about probably a pretty wide range of cumulative dose over time. And that part, I think there's imprecision about.
All right, so I think we're probably ready to vote on this moderate to severe. You can go ahead and finish the voting. Again, A is low value, B is intermediate value, and C is high value. All right, we have everybody having voted. All right, 73% intermediate and 27% high. Why don't we get at least one comment or two to help people understand the distinctions that you were thinking about in those two judgments? So somebody who voted intermediate, would you like to say what was behind your vote? I guess the main question is why not high, since those seem to have been the two choices. Anybody? Somebody? Harold?
Well, it was.
Sorry, make sure the microphone's close to
Sorry.
here.
I thought that just the cost per quality for the moderate group seems to be, as I interpret it, is probably over $100,000 per quality for the moderate group. And given that it's a mixture, I just thought intermediate was appropriate. And it's a little hard to say, but that was my thinking.
Okay. Anybody else who voted intermediate want to add anything notably different than that? Okay. Anybody who voted high want to say why they thought it was high? Ryan.
I voted high. While the dollar amount per quality falls in this sort of intermediate, I thought there was significant other benefits to the population and the folks around that support that population that justify bumping it to the high.
Okay. Mary?
So I also voted high, and there was so much that isn't in the report or the data that I think is probably there. I do a lot of obstructive sleep apnea work, and so long-term effects like lower stroke, lower heart, because they are sleeping, we now know how important that is. So my suspicion, because of the early data, was that long-term effects, and because of that, costs long-term, which is one of the outcomes, was going to be really impacted. So that's why I went high.
Okay, interesting. Any other comments that people want to add for the record about the justification for their votes? Okay, the next two will probably take less time because we've already dealt with some of the broader issues. The next two votes ask you to make a separate judgment for those with moderate atopic dermatitis who have failed topical therapy, and then we'll have a vote after this on severe. So I don't think we really probably need I guess we could just summarize what the incremental cost effectiveness, since that is the one piece that will have changed. And this, again, this is on page 9 of your evidence summary, but I'll let Marita.
Sure. So for moderate patients, we saw that they have a higher cost offset because they have lower underlying costs, but the drug costs are increased, the incremental drug costs, because more patients respond and so they're staying on drug. There's also a slightly smaller incremental health gain because that jump between the baseline utility and the responder utility is smaller. So more health costs for fewer QALYs leads to a higher incremental cost effectiveness ratio of $130,000 per QALY.
Okay. Any questions about that?
I'd like to actually add something now
Please.
that I heard some of the rationale
Yeah.
between the moderate and the high.
Uh-huh.
Being someone who is well controlled, not on something like this, my quality of life went way down. Like I couldn't hold my son at points, and outside of the quality of life and the productivity and the lost sick time just waiting in the doctor's office to get treated because the diagnosis was not a clear diagnosis in my case. That lost time, it would be very, very helpful to get factored in, but I can also say it meant I didn't go see other doctors. It meant I couldn't take time off to take care of other problems. So when we talk about cost benefits and these kind of lifetime things, I feel like this becomes the thing that you are trying to treat, and you have absolutely no energy to attempt to treat anything else that is going on. And I feel like that I would wonder in 5 or 10 years if you would see a different kind of analysis, even beyond, sleep deprivation and other things like that.
Thank you. Thanks. Don.
Meg, may I ask, and if you're uncomfortable with this, please don't feel like you're required to, but do you have other illnesses that are related to AD?
I do. I actually have asthma, but that was not the thing. There were, a number of things that started. I had just had a baby, so there were a number of things that change in your body kind of significantly, and now it looks like I'm running into some gallbladder issues that I think have been happening over the last 2 years, that I was accounting to stress and other things and sleep deprivation and.
But I think what I'm hearing, and of course we know that
Yes.
pregnancy is not a comorbidity, right? So we know that. But the important point I think you're making is that if this is the dominant problem, the other illnesses, as I hear it, may not get quite the attention or
No, and there's
concern
also,
that you should give it.
Absolutely.
Is that right?
And, my son is now 2, and he desperately needs to go to the dentist. And, could have gone to the dentist, last year. And, I know that, some pediatricians say 1, some pediatricians say 3. So we're still within, a wild window. But really, it would have been nice to take him to the dentist last year, but I overspent our HSA treating this.
Thank you.
Yeah, just to this point, just to discuss some of the patient's experiences that I've had. you know, I've had multiple patients where I've had to fill out the paperwork for disability that went away with dupilumab, just who went into the trials and actually got a job. We've had patients where, you know, it totally changed their trajectory in terms of careers and productivity. I had one young man come in and, you know, I asked him, how did the atopic dermatitis affect your life? Sort of an open-ended question, and his initial response was, well, you know, it doesn't affect me too much for work. Well, what do you do? I'm a professional gamer. You know, he lives indoors with the lights off. The only way he interacts with other people is through social, you know, networks. Doesn't go out, doesn't show his face in public. He has a job now. He's doing really well. You know, so these are the things that you'll never get in direct payer costs. He sort of suffered through it and coped, but it totally changed his life. And, you know, when you think about like life course epidemiology, there's this concept, you know, maybe there's a point of no return. Well, he had a point of return, even in his adult years, with proper intervention, was able to be productive again, went back to school, got a job. I mean, it's truly amazing to watch that change. And that's, I think, the efficiency when you're trying to apply a concept of QALYs, which is supposed to be the cost that society is willing to bear, and then only look at direct payer costs. There's massive costs to the patient and to the society that are not reflected in those models.
And I don't want to.
Thank you. I'm going to have to move us forward. Sorry. Thank you for those comments, though. All right. So why don't we go ahead? Any other questions that you guys need to put on the table before the vote? All right. Please go ahead and vote. There we go. All right. So we have 82% intermediate, and if I remember, that's 9 again, 9 and 2 high. Okay, I think we've had the discussion already about some of the justifications, and I can see the logic here. I'm sure you can too. Let's shift to the last voting question, which is severe atopic dermatitis. And again, just for the record, again, Marita, in the modeling, severe, the distinction, where was the boundary line? How was it defined between severe and moderate?
We defined it as it was defined in the clinical trials, which is IGA 3 for moderate and IGA 4 for severe.
Okay. I think you guys ask any questions you like. I thought that was the one thing I wanted to make sure that you had remembered again. If there's anything else, I think we've talked about other benefits, context, but please feel free to raise a question or if you'd like. Don?
Well, this is just a technical question for the dermatologist. So is dupilumab also considered a systemic treatment, or is there some other term for that?
I would consider it systemic, and especially, you know, it's in trials for other comorbid conditions, so we would hope that it benefits that.
So then, if Steve, just to English major this, it might be with other systemic treatments, I guess?
No, this is to be compared with no systemic treatment.
No systemic
So dupilumab, this means not versus
None at all.
cyclosporin.
No other
or methotrexate.
systemic treatment.
So it's compared
Right.
to, yeah, they will use topicals, but no systemic treatment.
And just a very quick clarifying
Yes.
question. I know the evidence suggested similar efficacy between once and every other week, or every week and every other week, and that the dosing is going to be the same between more moderate and more severe patients? Yes? Okay.
Good question.
And not to belabor that point too much, but again, you know, the moderate IGA is a static assessment, and it's a dynamic disease that's chronic, so it's hard for any clinician to divide them.
And we will,
Just
we're
on-
going to dive into that
Right.
deep pool.
And
when we get to
and
the
that's,
policy.
I wasn't going to say anything because I figured we'd talk about it in the policy roundtable, but I do think it's important for the previous vote, that I voted high, and part of my reasoning for voting high was I'm not sure making a distinction between moderate and severe is appropriate because it's such a static in time. And so I'm not, that was part of my rationale for voting high was I'm not sure making the distinction is appropriate.
And what that distinction, I think, boils down to in the long run is interpretation by payers about who is going to be able to get this drug. And it's going to make it very difficult for clinicians to address that.
Hold your powder, or keep your powder dry. That's what we're coming to. Don?
So So we talked about this a little bit beforehand, and I think we addressed it on the phone, but could you talk briefly, the dermatologist, again about the adherence factor with dupilumab compared to any other treatments?
We are, at least I personally, see a sea change. Adherence is just very difficult. With topical treatments, almost nobody can be adherent, and that's one of the reasons that treatment fails. With a drug like cyclosporin, that's a BID drug. It's got a lot of side effects. It tastes terrible. You got to get labs every month. Just a lot of those
But
are
non-systemic therapy.
even systemic therapy is hard to adhere to. Topical is the hardest, and then systemic is hard as well.
Would the patients agree with that? Debbie, do you think it was easier to comply with dupilumab as opposed to what else you were doing?
Absolutely. I mean, as weird as it sounds, I look forward to giving myself the injection because I know I'm getting the drug.
Whoa, that's pretty good.
I have nothing negative to say.
I have to add something. I mean, the compliance issue is a no-brainer. I will take my injection because I don't want to get what will come if I don't have it.
Yeah,
Thank you.
All right, I'm going to move us forward because we know we want to get to the roundtable to have the time to have all the different stakeholders here for some of these policy-related discussions. So let me invite the panel to do what they've already done, which is to complete your voting. So severe, we see 11 out of 11 for high value. All right? So the rationale behind that, I think between the shifting of the votes seems quite clear. And with that, let me thank the council for their votes. And actually, all of you except for the ICER team can stay where you are. And I'd like to invite up the other who are going to join us, for the round table. So that's Dr. Meeker and Marcia and...
We can close this.
There we go. Hi, come on out. I get to get away from this right now. Grab get the anchor and get this out of your way. Pour yourself a nice tall glass of water. Be able to walk around. So can you all hear me now? Is that all right? Okay, good. All right, so we are starting a little bit early. That's good. I know someone at least has to leave for the airport before 4 o'clock, but we have a good amount of time to try now to shift a tiny bit from discussing the evidence, both around effectiveness and value, and to talk about some of the issues that we've obviously started to touch upon, which is how do we think this information can best be moved into clinical care, the interaction between doctors and patients, perhaps clinical guidelines, decisions among clinicians, and obviously we want to talk a fair amount about the interaction with the insurance industry and how coverage policy will be developed, and all of that kind of also feeds into considerations around pricing and payment options that manufacturers have already obviously been thinking about for quite some time. Throughout the conversation, we'll want to try to identify great opportunities for future research. We've already done some of that. But I kind of wanted to start by going to the end of this end of the table with the patients again. So as you've heard this discussion, you've obviously heard a lot already about moderate to severe, mild to moderate. As you hear the discussion from the patient's perspective, do you feel like we're getting it? I mean, what's not on the table yet, or what's still not quite being appreciated enough as we start to think about how the evidence should be applied to clinical decision making?
Yeah, I'm happy to go first. So I'm just going to tell a little bit about, I was misdiagnosed. I was misdiagnosed with hives about 4 months after the birth of my son. I was covered within about 15 minutes of what looked to be raised bumps over maybe 60% of my body. I immediately strapped my son on and went to the doctor and was immediately shoveled off to the allergist. And once those would go down, I would be left with this kind of eczema-looking thing. I was at a teaching hospital, so I was with an intern who I feel like was not paying attention. I would send her pictures. She'd be like, yes, those are hives. And then 3 months into it, I was like, I don't want to see you anymore. And I was given the physician's assistant, and I was like, I don't, like, because I was on like a handful of antihistamines. Like a handful, like twice a day, multiple antihistamines, and they weren't making a dent. I was exhausted. I had a 7-month-old who wasn't sleeping through the night. And so then I was begging to go on Zoloft. And so everything's a wait and see process. Okay, now we're going to wait 6 weeks and see. Okay, well now we're going to see if Zoloft is right. Okay, well now we have to wait for your insurance company to say Zoloft is okay. Okay, now we have to wait for the Zoloft to come in. So we're talking almost a year into it when finally the physician's assistant and I were like, this isn't gonna working, and she's like, I'm going to recommend you to Northwestern. I was not at Northwestern at the time. So she recommended me to someone who then gave me a punch test, who got me to Dr. Silverberg, and he diagnosed me with eczema with allergic markers. So dermatology does not exactly have the shortest wait period. Took me 6 months. The earliest I could get was 6 months. And then I put, and I'm just giving you kind of all of this to kind of understand. So I put a Google reminder in my work calendar, and I'm still on Zoloft, which is at least an hour and a half appointment because it's 20 minutes to mix, half hour there, half hour to wait. Like it's not a short appointment.
Every 2 weeks.
Every 2 weeks, yes. And so every 2 weeks I would call his office to see if anyone had canceled. No, like it really took me 6 months to get in. And in the meantime, then the New York Times article came out about this shot, and I was like, good God, thank God I was in before that came out, because I would never get in. I can't imagine what his wait time is now. The moment I walked into his office, I was probably covered with, easily, my entire back was covered, and he looked at me and he was like, I was there to do a patch test. And he was like, I can't do a patch test. I can't read a patch test. And it was the first time that I got put on, a kind of all over steroid, and to clear me up to do the patch test. But he looked at me and he was like, who told you this was an allergy? And I wanted to hug him because I was like, I know it's like everyone keeps telling me not go off of these things, but I think these things are just reducing my quality of life even more. And sleep deprivation is a torture tactic. Like literally defined as a torture tactic. And you're talking about patients who are living like that. And I have a very small staff at work. I'm a director of exhibitions. I run 3 galleries with 2 staff members and a series of small group of students. I do all of that to pay for my other career as an artist. And that's not that I don't have a career. Like I've shown at the Museum of Contemporary Art. I've shown in the Brooklyn Dumbo Arts Festival. It's just those things don't pay. Like they just don't. That's just the way the industry works. And so you're talking about eating into both of my careers, neither of which is okay to ever have a misspelling. Or you can't, I run a budget, I can't misadd, and like my mind just wasn't functioning. And I also run safety and security. I have to look at sculptures and be like, are they gonna fall on anyone? Like we have an opening with 1,000 people coming. So my job is to stop other things that are specifically precariously made from hurting someone. And I had to do all of that kind of not on any sleep. And take care of a newborn who, if I didn't cut his nails, when in which he touched me, I would scream. So in a lot of ways, I don't think there's a lot of understanding until you've gone through it. I don't have cancer. I'm not going to die. In no way is this terminal, except if I good thing I don't drive, because I would probably fall asleep at the wheel. But I don't think there's an understanding that just because this is not a life-threatening disease, that it doesn't totally diminish your life. And I am shocked and just incredibly sympathetic that I'm not the worst of the worst. In any way, shape, or form, and that I can't even imagine what that does.
Thank you for sharing that with us. Debbie, I might spin the question a little bit differently to you, and in terms of, as you know, Dr. Rinn mentioned, there's clearly been a pent-up need for this for patients with very severe disease, and yet it's brand new, a brand new mechanism of action. Do you think in terms of how doctors and patients talk about that, is there a way that, you know, the evidence as it exists today for a new drug, it's obviously very exciting, as we've talked about, how should the caution, if, you know, around longer-term data and uncertainties, how should that be made part of the discussion with patients, do you think?
Wow, okay. Well, for me personally, I mean, when I was told about the trial and to get on this biologic, for me it was all about just the quality of life. And I think that you have to weigh the odds, and a lot of that depends on probably where you are in your life and age or whatever, but for me it was just, I really didn't have another option. I had tried everything, and I was very open to it. So I think that, you know, we take the information we have and we have to, it's individual basis, just decide if it's the right thing for you. So.
Okay. Thank you, too. Just briefly with the clinical experts then, how do you think, you know, clinicians today should counsel patients regarding the long-term, you know, relative uncertainty around some of the benefits, but certainly around the potential harms? You know, risk for, we've all seen multiple sclerosis drugs, other kind of autoimmune drugs sometimes do have very severe problems that don't pop up until 3 or 4 years downstream. How, if at all, should that factor into how you think about which patients to treat and how you talk to them about the risks and benefits?
One of the things that people often lose sight of, especially with the new drug and relative unknown risks, is the risk of the disease. And we don't even have a great handle on the risk of the disease for this drug. What we are hoping, you know, with new interest in this disease is that we're going to be able to find out more, because don't forget, government is not funding any new research for this. This is all funded by the pharmaceutical companies. And if you look at what's happened with psoriasis and everything that we've learned that's mostly funded by the billions and billions of dollars of new drug development, it's pretty amazing. So, you know, when you talk about the risks of a drug, you know, you sort of have to take into account what we know about this pathway in general, and we don't have a genetic correlate for this pathway. There are other biologic agents where, you know, where there's a genetic disease that lacks, you know, that same, you know, pathway, and we really don't have that, as far as I know, for IL-4. There's no IL-4 deficiency genetic diseases that I know of, and you know that either. I don't exactly know what that means, but I only think that the risks of the disease and sort of being very targeted with this pathway, the other drugs that we're using are not targeted at all. They're kind of like big hammers as opposed to little screwdrivers. And I can only think that this particular drug would be of benefit much more than the risk. I think it way outweighs that. I think the biggest issue is, you know, I don't think it's going to benefit 100% of people who get it. That's the hardest part. We don't have a biomarker to predict at this point, but I really think we're going to have that. But if we cut off accessibility or the availability of this drug after such a huge investment has been made in it, that's going to have a huge negative impact on the pipeline.
Jonathan, anything you'd like to add?
Sure. So, I guess for full disclosure, I myself have eczema. It's part of what makes me passionate about it. I would have no hesitation taking it myself, probably lifelong until I developed immunogenicity and lost efficacy. Having seen patients in the trials and seeing not just the life-altering aspects of it and how it changed their life, you know, it's a tearful moment. You know, they come in wearing shorts for the first time, like ever, and you know, in 10 years they actually are getting a job. I mean, it's an amazing thing to watch that, you know, progression over time. And it's not, even now, you know, we talk about the conjunctivitis signals. And, you know, so we had patients in the trial who had the conjunctivitis. And for a couple of them, it wasn't so trivial. And you know what? They said, I don't really care. I don't care what this thing throws at me. I will stay on this drug forever because I can't go back to what I was dealing with. You know, I'll give you an example. I had a conversation with a mom, not about dupilumab, but just about aggressive management, systemic management of atopic dermatitis, and a 10-year-old child who hadn't been in school in 4 months. And the mom was very hesitant to pull the trigger and go to a systemic agent. They said, well, I understand your concerns, but don't you think being out of school for 4 months is also going to have an impact on the child's development? And it's like, oh, okay, there's this epiphany. You don't realize just how bad this disease can be because, if you had a kid with it, pretty mild, say, okay, it's just eczema. But, for these, and even in the moderate spectrum, that's why I don't agree with that whole distinction either. There's a broad range of moderate, and within the moderate, on the higher end, there's pretty much, you could arguably just call it severe. It's debilitating. I mean, it's completely and totally life-consuming in every way. And every patient's affected a little differently because of that heterogeneity, but it's the same story. I mean, it just totally ravages them. So could there be some signals down the road? Possibly. We do know a lot about this pathway. We've had thousands of patients who've been treated with this pathway targeted with dupilumab in asthma trials, with other agents that are targeting IL-13 specifically in the number of hundreds, and in atopic derm and thousands more in asthma. And so you're talking about cumulatively about 10,000 or more patients who've been treated with this pathway targeted, and really not seeing much other than this class-wide conjunctivitis signal, which only happens in the atopic dermatitis patients. So yes, 10 years from now could be a very different story, but we're here now, and there's really nothing to speak of that I'm worried about in the slightest reservations from a toxicity standpoint, especially when the alternative is cyclosporin, where every day you're killing another nephron potentially, and prednisone, where I've had patients who've had psychotic breaks and had to be admitted to the psych hospital because of the prednisone, let alone the atopic dermatitis. So I think it's a no-brainer because we just don't have anything else to play with. Now, would it be different 10 years from now when you have multiple biologics in the marketplace and you have to figure that out? Okay, we'll have that conversation when it comes. But to me, it's just a no-brainer.
All right, thanks. So I think we'll work our way back into kind of maybe even building a coverage policy with different considerations based on the evidence, some of the things that we know go into coverage policies. But let me skip down, and actually I should have been a better host and invited people to introduce themselves who've now joined the policy roundtable. So if I can start with Jeremy and just kind of have you guys just introduce yourselves briefly. And we can see you're up here, but just tell us what you do at your companies. That'd be great.
Sure. So I'm Jeremy Friedel. I work with Express Scripts. I'm the director of trend management. So I work with the formulary team and our utilization management team to design how our benefit will be put together.
Great. Marcia?
Hi, I'm Marcia Fisher. I'm representing Anthem, Blue Cross Blue Shield of Missouri. I'm the medical operations director, so I'm the clinical lead for the utilization management team, specifically the physicians that review for medical necessity for services.
Thank you. And David?
Yeah, David Meeker, introduced myself before. I'm head of Sanofi Genzyme and responsible for the overall business unit, if you will, partnering with Regeneron, making dupilumab available. So.
All right. So thank you all for being here. So as I mentioned, I'd like to jump down to David. Since this drug is now in the market and has been priced, can you, and much of this is in the public domain, but can you just share, given the unmet medical need, given that this is the first drug in its class, how did your company arrive at a price that you deemed would be, I won't say fair, I'll say, maybe I shouldn't say anything. Tell us the story of how the pricing, because I want to segue from that to the way that we think about value and whether long-term value for money and short-term affordability can sometimes be in conflict. But tell us about the pricing.
Yeah, so maybe just to back up briefly. So I think the discussion so far this morning has been great, and I think as a physician leading a biopharmaceutical company or unit, how we think about this drug, and particularly this discussion of mild, moderate, and severe, which gets to the pricing question. Those are terms that we use in clinical trials. IGA is broken into 4 or 5 point scale kind of thing. They're terms that we use talking to each other when we say, oh, I have a mild patient. But when I say mild and the person I'm talking to and they hear mild, we may be talking about totally different things, but I know what I mean by mild. And that, at the end of the day, medicine is an art. And no matter how much data we have, and all these aggregated data sets and the like that help inform us as to what to do, when you're in front of that one patient valuing their risk tolerance and your understanding of the risks and benefits and whether they're going to be all the myriad of things that go into saying what's the best treatment for this patient, that's an art for the most part. So as a pharmaceutical company, our goal and my goal is to say, how do we maximize the chance that the patient will get the right treatment for them? So in this world, it was, if you can be managed on a topical steroid, why would you take an expensive biologic? And so that was very easy. Now, forget mild, moderate, severe. For me, it's just, if you can be well controlled on a topical steroid, and we can talk about the other topicals, but certainly on topical steroids, you're good. You don't need this drug. If you can't, and you're in front of your physician saying, I've exhausted my ability to respond to a topical steroid and I am still suffering, then you have two options, which is you can continue to suffer, or I can put you on another drug. And then you get into the discussion we have. And so that was the goal, to say, to enable that discussion, to make sure that the best possible decision could be made. Now, from a financial standpoint for a company, it is crystal clear. If we can get that set up, this drug will do fine. We don't need to sell the drug to a single patient who doesn't need it. I mean, this is strictly, in fact, that will be bad. And so our instruction to the sales folks and the like out there, which is, you are to be the biggest champions for topical steroids, because I don't want to see any patient who can be managed in that world on this drug. It will not, it's in no one's best interest. So then how do you price a drug? And so this is, again, a myriad of things. And some of the things that go into it, so fair, we try to be fair, but it was looking at this issue of access, recognizing, yes, you need to get a return on an investment, which is quite significant. One of the things, and I shared this with David earlier, the numbers that has become quite clear is that the amount of time that you are alone in your class has dropped from 5 years-ish to 2.8 years. Okay, which means that this concept of competition entering the space, we think about the generic world, you know, you have your product for 10, 15 years, and then generics come and it drops. 90% of our world's on generics. In the biosimilar biologics world, that's much more complex. It doesn't move so quickly, it doesn't drop quite as fast. But what's interesting is that world is changing, and in fact, the payer world is increasingly willing to put, if you're in the same class, to put you head-to-head with that class and say, you know, you guys compete on price, you're close enough. So that goes into it. Secondly, the costs, all the things that go into an ICER evaluation go into it. And we worked with ICER in what was a highly, I think, productive dialogue. We do our own models, ICER does their own models, and they came out, I think, remarkably similar. And so that's an important factor. It's not the only one, and we can talk about how we think about those tools. Three, this biologic world is price sensitive, but it is not perfectly price sensitive. So there is a wide range of prices over which you could set the price, and it will not change behavior at all. And it will not necessarily change, you know, the rate at which drugs are taken up. So bottom line is, we took all that into account. We looked for a price that was below the other biologics that were out there that were used in similar kinds of diseases. We'll discount, you know, somewhat below that, and we'll go from there. And we're not locked into a price. So a bit of a ramble, but
no, that's very helpful. So in your organization's discussions with us, it was clear that you were thinking hard about the long-term value for money, and you were very open to your own modeling and to ours and to thinking about that. So
can I just add one
oh,
piece?
Sure.
Just back to the lumpiness, because I didn't maybe make that point clear enough. All things being equal, if you had this drug forever, for a long period of time, your area under the curve, the price at which you could set would be much lower. And this industry, unfortunately, the development and investment period is this famous, 10 to 15 years, which is remarkably true, and we could debate that, but I think I can hopefully convince you of that. So it's a long time to get to the point where you get to return. Then you have this increasingly shrinking period of time over which you do get that return, and then society gets the drug, certainly in a small molecule period for pennies a day for years. In the biologic world, not pennies a day, but I think that those numbers are going to come down in a way that says this totally works. And the reason we have the drugs is because you have that potential, the reward. This ability to get your return drives that innovation and that willingness to invest. And the clinical trial discussion we're going to have here about what else needs to be done, and this is a great drug where there's an enormous amount of investment that needs to go behind this drug for it to see its full value, meaning for the patient, for society, for the company ultimately, will require significantly more investment. So those are all factors, again, going to.
Great. So,
Can I just add one little thing to that? Because if you compare this drug to, say, the psoriasis drugs, not only did these not have to be studied in children at all, the FDA actively blocked that, and now the FDA is requiring it, and I can't imagine how much the pediatric development process is going to cost, but it's required, and there's a commitment, and there's never been anything like that before. So, it adds to the cost.
So talking about the long-term value and many of the other features around needing to prime the pump for future innovation, et cetera, the other side of thinking about short-term affordability is the kind of implied opportunity cost in the health system and across the health system. We know this week that Washington is all ablaze because some people will say that we can't afford health care for 23 million more Americans over the next decade. So is that because our healthcare system is too expensive or because we're not using the money wisely? But let's try to look at this case in particular. So there are approximately 17,650,000 Americans with atopic dermatitis. And we've kind of worked with the national groups to try to get these numbers. There was a source that suggested that about 10%, no, sorry, not 10%, but yeah, around 1 in 10 were not adequately treated with topicals. There's a source for this information that's in the report. So that's 1,765,000 Americans. Now the company publicly has said that they view the need is 300 to 350,000 patients. First, I'd like to ask you, maybe clinical experts, but since that's your company's statement, where did that come from? How are you going from a statement that 1,765,000 don't have adequate treatment with topicals, which was where you started? How do you get from there to 300,000?
So it's not that 300,000 are in need. It's that 300,000 we believe are a number that are likely to be able to access treatment. And not simply because of pricing, right? In fact, I would say largely independent of pricing. I mean, if you go, for the best analog, so the psoriasis world, 14 years after biologics and good therapies for psoriasis come out with exactly, amazingly, the same kind of demographics, 1.7 million or whatever, people uncontrolled, moderate to severe, under 300,000 of those patients are getting treated with biologics. 14 years later.
Now, is that because of insurance company provisions and other things?
No, I think, so every one of us owns a piece of that, but in our world, meaning society, world that we live in, there are many, many reasons patients fail to access care, right? Wrong diagnosis, Meg's, description down there. How many years do patients sit there circling and go, that's not a rash, or don't worry about that. So that is a much, much bigger issue than that. So if we could say, no, there's going to be 1 million people who are going to line up in the first year, we would have priced it differently. Absolutely. That's the hepatitis C issue, right? I mean.
So let me follow through with that.
Yeah.
So just implicitly then, we're talking about 1 in 6 of the patients who, from a clinical perspective, not only could benefit but might need it, gaining access. If you take 300,000, even the lower end of that number, times the $30,000 per year, which is at the lower end of the net price, that's $9 billion per year, which would make it the second biggest selling drug in history, behind the cure for hepatitis C.
Yep, perfect. So, 14 years later,
right,
maybe, 2.8 years, there's significant competition in whether it's IL-4/13 class, whether it's a brand new approach to atopic dermatitis. This is one of the most intensively studied fields. And the bonus of dupilumab is that it has been one of the drivers for driving the research in this. Knowledge around these kind of diseases happens when you get therapy. We work in the rare disease space, Genzyme is a company, and one of the biggest problems is you enter there and nothing's known about the disease until you have a therapy. And then suddenly patients start coming in, the disease starts to be studied, you have registries, you begin to get long-term data. I will argue, and I'm going to let the experts comment here, that's this severe end, moderate to severe end of atopic dermatitis. It's poorly understood. Now we're going to learn an enormous amount, and it's going to make this group much more accessible for further study because you know more. We're going to get biomarkers. The trials will be accelerated. I mean, there's a bunch of stuff that's going to be enabled by this.
Can we stop for a second?
Oh, absolutely, absolutely.
Okay, and I think Rachel wants to say something after I do.
Use your 10 card so that I can.
Okay. Oh, sorry.
See if you guys do. So go ahead, Ryan.
I need to make a comment that I don't while there may be some that is misdiagnosis and people aren't getting access to, let's not pretend that in this country, it is not because we have, at the current time, close to 30 million uninsured. If things change this year, it may go back up to 50 million uninsured. And I suspect that there's a higher rate of uninsurance among folks that are diagnosed with this disease. So my educated guess is that that is a huge driver of why you are only going to see 300 or 350,000 people access this drug, is because we as a country have made decisions to leave 1 out of 6 or 1 out of 7 Americans without health insurance and without access.
Rachel?
Oh, just to follow up, I was thinking about people who are maybe unable to work because of the severity of their condition and who can't access employer-sponsored insurance, which of course is the way most of us get insurance. And so if we think about, Medicaid and its availability, then we should be very concerned about that. One follow-up question maybe for David is, you use this 2.8 years. We would know if there were companies already in clinical trials then who would be expected to be approved within that time. Are there companies already in clinical trials that look similar? And would you not have an incentive to try to get more patients onto this particular drug once you see that those products are submitting NDAs and are likely to be approved in the near term?
Yeah, no, it's a very good question. And so, Jonathan said, the IL-13 class is out there. This is a unique drug in that it's the combination. There are no other IL-4, actually that's not true, believe it or not. So we internally have a different mechanism of action targeting the same. Now, we're not going to compete with ourselves, but I'm just saying that we're out there, not publicly in trials about some of this stuff. But the answer to your question is nothing's in late stage, so the 2.8 is not going to apply to this specifically. Right. So it's a very good point, it's fair. But it will I think it will accelerate, that's my point.
Right. And the pipeline looks pretty robust, at least for what's in the public sector.
Right. Just to get to the point, biologics in psoriasis, so for us in dermatology, psoriasis would be the best model to sort of compare this to. You still only have about, I think the number is somewhere around 20 to 30% uptake in dermatology practice, because there's some dermatologists who choose to go a different direction other than medicine and go towards aesthetics. So that just makes it even harder in terms of that bottleneck to get into specialty care, which is a disaster in this country. And it's not going to get better whatever happens. So, anyone who lives in a rural area, they're just denied, they don't have access to dermatology. If you live in Montana, you're screwed. I mean, there's just no one, there's like 2 dermatologists there. If you live in New York, you have I joke around, you have a dermatologist on every other street corner, and most of them are doing cosmetics. So there's always going to be these access issues, and there's always going to be a select group of docs who are going to be comfortable using this. And that's the reality, that no matter how many moderate to severes there are, even if someone gets into the healthcare system to utilize, they're never going to get to the right folks who can use this drug. So I don't think you're ever going to get a balloon beyond that, to that point where you have all of them. And we have data from population-based studies that there's a large swath of the population that just don't even utilize. Now, part of that could be they've just been unsatisfied with the awful option, so maybe some come back into the system, but I don't think they have any place to go to. So I don't think you're going to really hit that number that you're concerned about.
Well, the 300, the bottom of that range, at the bottom of the pricing, gets us to $9 billion a year. So I guess my point was that represents payment for a treatment that the votes have decided, represented, clinical excellence, if you will, or clinical superiority, and good long-term value. Kind of from a health system perspective, we have to now wrestle with that $9 billion implicitly has to come from somewhere, and it can't go to somewhere else to pay for someone else, whether it's someone else's insurance overall or whether it's other treatments. It has to, or it can come out of taxes or wherever. Ultimately, the payers, private and
Steve, can I just highlight just one?
Yeah.
You just have to be careful about, I'm really sensitive to the math, right? The math is right, but the question is that reality? I mean, that, the famous PCSK9.
Well, we're going to talk about reality, because you would want, you said you only want the people who really need it. You would want $9 billion because that represents The
I
minimum
want
number of
everybody,
patients, right?
absolutely.
Right.
But there's a reality, as you said.
Oh, no, right.
But if the world just says, oh, this is it's not a $9 billion drug. If this is a $9 billion drug, we would have priced it lower.
Okay, I think the
That's the
latest
point.
analyst estimates are 5.5 billion within the next 4 to 5 years.
With asthma.
Right.
With nasal polyposis.
Right.
None of those savings are being factored in. 40% of the patients in the trial had concomitant asthma. So even in today's world, atopic dermatitis, just staying on label, there are comorbid, significant savings that are coming to the system. So again, my only plea here is, this is so complex, and what kills us is headline. And I think it's a complex thing. It requires time for people to sit down and say, let's hear the different pieces of it.
Right.
And
So
Ryan's point is exactly right.
That's where we're headed.
I do want to put
I
a point in just.
I need to keep going, because I want to give the insurers a chance, because ultimately, any tension that we sense between good long-term value, unmet clinical need, clinicians excited to use a new drug, concerns that, if you will, that you're supposed to capture from broader society to try to help us make prudent use of healthcare resources. I'm going to ask you some specific questions across the board here, as we'll kind of walk through some of the options that are usually considered by insurers as they bring in a new drug like this. But what's your first reaction as you think about, and as I'm sure your companies have already commented publicly in some sense, about the pricing and about the ways that an insurer would begin to think about how to apply the evidence on effectiveness and value to a coverage policy? Jeremy, you want to go first?
Well, dupilumab, we believe, has been actually an excellent example of how the different organizations can work together. There's been far more transparency about the drug, what the anticipated uptake will be, and the pricing. So Hep C was mentioned earlier. Hep C was kind of the opposite. It was more of a big surprise, and it caught a lot of payers and health plans off guard with how much it was, plus the number of patients that sought therapy so quickly. So with dupilumab, and I think the ICER data plays that out, it's right there kind of in that sweet spot. And I know our chief medical officer kind of had said that probably nobody will be happy, right? The insurance companies will wish it'll be a little bit less expensive. Shareholders will wish it'll be more expensive. But it seems to be falling in that sweet spot based on what it's labeled for. And I think as a PBM, that's one thing our management strategies will have to watch for, is it being used in that sweet spot, or do we start to see the use start to go in other directions that could change the numbers and the values that were presented today?
All right, let me let Marcia comment, then I'll come back on that too. Go ahead, Marcia.
Well, based on the medical evidence, Anthem has pharmacy benefits for crisaborole and 3 basic criteria for that. And our decisions regarding our criteria, both for our pharmacy benefit for crisaborole as well as pharmacy and medical benefits for dupilumab, are based on the evidence. For crisaborole, 3 basic criteria are looked at: age 2 or older, mild to moderate disease, as well as failure, intolerance, or a contraindication to a topical corticosteroid, 1 or more. Our medical policy is drug 94, and probably takes a little more into consideration in terms of who are the right candidates for treatment. And again, based on our medical evidence that we have, it's based on 5 criteria. Again, they're reviewed by our staff for medical necessity. So age, 18 or older, moderate to severe disease, chronicity, failed topical, and that can be corticosteroid or another topical, as well as consideration for failure of other more conventional treatments, whether that be phototherapy or a systemic. And based on...
Sorry, to make sure I caught that last piece. Sorry, failure of other systemic therapy?
Or an intolerance.
Or
a
failure
contraindication.
or contraindication to other systemic therapy. Okay. So real quickly though, does that mean that a patient has to either be contraindicated for cyclosporin or phototherapy, or have tried one or the other and failed it?
One or the other.
Okay.
Failed or intolerant.
Okay.
or contraindicated.
So I was going to start to almost kind of work with you to comment on the different pieces of a structure that you've helped us kind of see. And Jeremy, feel free to chime in. And again, I don't need necessarily to put you on the spot to say exactly how you're covering something if that's not something that you can share. But you can talk to us about, if you can't say that, just kind of how you would generally think about applying the evidence to this area. So we've got an issue around, sorry, Ryan, go ahead.
Just on that last comment, I thought we heard from the clinicians earlier that you wouldn't choose to put your patients on the cyclo before dipalomid, but now the insurers are going to make you? Are you experiencing that already?
We're experiencing it. We're frustrated by it. We think there's some major ethical questions about mandating an off-label use with that level of very well-established toxicity.
Right.
Especially when you have this patient population where you already know they're chronic. We have data to show once someone's chronic for years, they're going to stay chronic. So what's the point? You're just kicking the can down the road. You're exposing them to unnecessary toxicity, and then you're going to have to switch them to dupilumab anyway. So to me, I just don't see it. I think the other pieces of the puzzle are legitimate. I mean, how you assess that is a different question, but I wouldn't want to give this drug to anyone who would just be fine on a topical therapy, and I think almost everyone would agree with me. Moderate to severe matches the inclusion criteria. That's the patient population of the greatest unmet need. The chronicity is going to be essential if you're going to be using a long-term biologic, so all that makes sense. But I think, and the step through, though, on a systemic agent beforehand, I have real problems with that.
In this specific example, was it phototherapy or a systemic?
Phototherapy or systemic, and systemic
Does that change
is not limited to cyclosporin. That
Right.
might be prednisone or.
Okay. Does that
But
change?
all have the same health
Right, so
risks.
phototherapy,
Or similar.
it hasn't been around quite as long. The safety signals are not quite as clear, but skin cancer is a legitimate one. There are real concerns. My biggest concern with phototherapy is not or is not as much the safety signal, it's more of the efficacy issue.
Yep.
Because it just doesn't work in the severe patients. In fact, it often flares them up because of the heat and sweat component, which you've heard a few people allude to already. So, for someone with severe disease, and it takes very long to work.
Yeah,
So,
I'm familiar with this.
So you're forced to wait for a minimum of a month to even start to really see efficacy, especially on those thick lichenified lesions. And you're talking about a 4-month halt till you expect to see some real results. And so you're forcing them to wait that long to fail, and when you knew already they weren't going to be a good candidate for it. That's one issue. The other one is access. I mean, phototherapy is very rare now. I mean, it's not exactly covered well to begin with now. I mean, it may be the lesser of two evils cost-wise in the new marketplace, but for patients, it's just, if you're a working mom, it's just impossible to get access to. If you're in a rural area, there's no place to go. Home phototherapy has no demonstrated efficacy or safety. There's not one study, so it's really challenging.
So I piggybacked on that, but my actual question that I wanted to bring up has to do with the efficacy of it. So, I mean, when you look at the trials, and granted they're early, but we're looking at 4 out of 10 patients at best, right, are going to benefit. If I read the studies right, maybe that's giving the benefit of the placebo.
You're talking about for dupilumab?
Yeah, I am.
I think I'll jump in front of them. That's for the kind of true success, which was an IGA at 0 or 1 and a 2 change. I think a lot of patients made progress on the EASY score. So I think
So we see
most,
at the EASY 50 anyway.
So, yeah, the EASY
Okay.
50. A lot of clinical experts would say
we're at 80 to 90%.
Most patients derive some, if not a lot of benefit.
Well, I'll put aside any anecdotal discussion, just looking at the data and trying to understand it properly. Of those who were non-responders at week 16, 24% ended up becoming responders at week 52 in the Chronos data, which is the longer-term data. So for many, you'll extend over time, you'll get to that endpoint.
So you pick up another 24%.
Right, you eventually get there. Now, so that's one endpoint to think about. The other thing is this IGA score is an idiotic measure, honestly. I mean, the FDA chooses it. The more meaningful measure would be an EASY 50, where 85 to 90% achieve that endpoint at 16 weeks. So to me, that's how I approach this, and that's how I discuss this with patients. 90% of patients are going to do very well, and then you're going to have like the EASY 90 is that 40% response rate where it's going to be amazing.
Right.
But for most patients who are in that severe spectrum, they don't care about being clear. They want the itch better. They want to be functional again. So 50% response to them is a response. I mean, that's big. And then you throw topical steroids in conjunction on top of that, or some other topical therapy, you get a little extra boost on top of that. That's the sweet spot.
So in your experience so far, you haven't had many patients, or you don't anticipate many patients where it's not effective and you're continuing, like the question is, how long do you continue a very expensive medication when it doesn't actually demonstrate its value? And at what point do we as a society or payers say, okay, that was a good try, but in this particular patient, we're not continuing the benefit, if that's even a possible thing to do?
Let me make that even more pointed, because that was
Okay.
one of the elements of a prior authorization criteria that I wanted to come to, was stopping rules for both drugs. Because this is something else, as you pointed out, that we often think, at what point does it seem not reasonable to continue if there's just a little benefit, or how far do you keep going? And similarly, if you're getting a huge benefit, is there a clinical rationale for stopping and seeing if they continue to need it for every month for the rest of their life? Would you really keep someone on it for 40 years and never try to take them off of it to see if they need it? So an insurance company is going to be writing a policy that's going to say stopping rule X. So let me circle back here, because you guys have already started to think about this. Jeremy, do you guys have any kind of stopping rules built in, either for crisaborole or for dupilumab?
So for Eucrisa, to kind of switch over to the brand name for a moment, no, there's no stopping rule. So it would be a conventional PA in terms of the way it's reviewed. If it's approved, it's for a year, and that's for that year. And at the end of that year, they would be reviewed again. But presumably, you passed the first time, you're going to pass subsequent reviews as well. Now with dupilumab, we have a review that of an initial approval, it's 16 weeks. And that was just based mostly on the response time frame that they used in the clinical trials. So they want to reassess them after 16 weeks to see if they've met some of those responses. But in our PA, there's a distinction between ours, and I think you guys know this. All payers are not using, obviously, the same PA criteria. So at Express Scripts, our standard criteria does not include phototherapy. It doesn't include systemic agents. It just has the patient use a topical agent. But after 16 weeks, it's going to ask about response. But we're not going to use any particular measure. We're going to leave it up to clinician to determine, did they have a good response to the medication, and then proceed with the review. After that, it would continue to approve at a 1-year interval.
Okay. Might as well ask you briefly, do you guys have stopping rules built in for either drug at this point?
1 year or an annual assessment of medical necessity or prior authorization.
Okay. Do the clinical experts feel like it would be unreasonable to have a stopping rule along the lines of what Jeremy described, in which if the patient is not judged to be improving after X number of weeks, that should be it?
I think that the requirement for that is just sort of based on, how much demonstration of efficacy you have to, like, what do you have to do in order to jump through that hoop? Right. But, in terms of criteria and step edits that are required, I understand the evidence-based criteria, age, if you just want to dumb it down to a single thing. So, if we don't have evidence basis, then patients can't get the drug, in this case, meaning less than 18 years old. The exclusions are evidence-based, but the prior authorization requirements are non-evidence-based, meaning you got to fail a steroid or even prednisone, which is by our guidance criteria for dermatology. We consider that contraindicated drug even in this disease. But so the step edits are non-evidence-based, but the exclusions are evidence-based. It's a little bit of a non sequitur.
Well, I think, again, to try to play devil's advocate, insurers see the full spectrum of clinical practice, not all of which is as informed and up to speed as you guys. And they will probably see requests for this drug to treat, hangnails and, things.
That's a very important point.
So they need to have some kind of framework. And so we've been focusing on kind of the failure of what, and how do we define failure? And then hopefully we'll get back to kind of what's moderate and severe, or mild and moderate. But this is a huge issue for clinicians, for patients, and for insurers, is how do we take the existing evidence and create some boundary around, I even started with, 1,765,000. We know that that's 10% of the 18 million who have atopic dermatitis. So if we're all clear that we don't want 18 million Americans on this drug, how do we create a quote-unquote evidence-based process for deciding who should get it? So let me circle back to the insurers. Have given you a chance to say what you wanted to say about the kind of the failure of, Marcia, did you want to talk any more about, the failure, because you have something in there about, for dupilumab, having to fail some other systemic therapy.
Or phototherapy.
Right, with some people, right.
So I guess the criteria is based off of not just failure of a topical, and it can be a single topical agent, but also another failure, a medical failure that's non-topical.
Right. And I know you work with, as many insurers do, or most work with clinical experts of their own.
Mm-hmm.
So, we're hearing some tension here. The drugs that you would ask patients to take before dupilumab are not drugs that clinicians would want to try. So is the process involved as they tick a box that says, I don't think this is indicated for the patient, and that's all that they need to do, or is it more complicated?
It's more detailed. I will say that we have a medical policy committee that's consists of clinicians across the country that actually help us form our medical policies. So there are clinicians that formulate and update on a quarterly basis our approach to treatments and the policies that we apply. You had another question.
If I did, it's left my brain as well.
That's okay.
Because I know what I want to ask next is I want to ask David. So, and with apologies.
Can I ask Marcia if that committee is it the same people or is it different clinicians based on their expertise in a given area, or do you have just a set committee and they review?
We have a diverse committee, primarily of clinicians, and they have term limits. So they're on the committee for 2 years, 3 years, and then they rotate off.
So there aren't necessarily, so when you're reviewing this drug, there aren't necessarily a dermatologist that's on that. If there doesn't happen to be, then there doesn't happen to be during that review. I just am wondering how you came at that.
If we're talking about the initial review, that could be done by someone who is a primary care doc. By the time a reconsideration is accepted, so let's say we deny the drug and a doctor is appealing for reconsideration, that is also done by any type of specialist. By the time you reach the appeal level, it is a like specialist. So dermatologist, maybe it's an allergist. So by the time you have triaged your way through a denial, ultimately, if it's denied on multiple levels, you get to the appeal level where it's the same specialist.
I'm just thinking through what that means to a patient in the real world, and Anthem making these requirements that are not based on evidence makes zero sense to me. And so there's some pretty strong ethical concerns for me that there are requirements about trying another systemic agent that the evidence is not there that should be clinically required by the insurer. And so I'm putting you on the spot a little bit, and I don't mean to. I just to me, there are some strong ethical concerns for that.
Our medical policy committee does look at the evidence when we formulate the policy. And if it's on the policy, there's someone on our medical policy committees that, they're in agreement that maybe there's a difference of opinion about what would be considered standard.
Yeah. And our reports are meant to feed into a wide variety of processes at different kinds of payers, and so that's part of the process. And
Can I ask a question?
Everybody sees the evidence in the same way.
Is there a dermatologist on the policy committee? Is there someone who's actually had experience treating this disease, particularly in the moderate to severe form?
Every specialty is represented.
Yeah. So I guess I would ask a question to
I'm going to go briefly around because we've had some people also. I just want to make sure in time of who put up first. Was Shumei, were you first? Okay, we'll go around.
So I just have a question for Marsha. The first question is, how frequent you change your policy? Is it easy to change your policy? The second question is, with the available evidence, your policy, do you think is make your organization liable because you are putting patient legally liable because you are putting patient with the medication with significant side effect before, the medication that have better evidence, better outcome?
Well, there's legal input at every step of the way in terms of our formulation of our policies and guidelines. So legal evidence is taken in consideration too.
Don, and then Harold.
Yeah, well, let me back away from.
And then there are quarterly reviews to completely answer your question. Policies and guidelines are reviewed quarterly, and based upon whether or not the committee feels that there's enough medical evidence to change, for instance, a policy, will determine how often that policy is changed.
Yeah, I would hope we could back away from worrying about if an insurance company's medical policy approaches hocus pocus, because I know it's not, and make an assumption based upon what Dr. Fisher has said, that, because I know this, that a lot of time of effort and professional input goes into this, and it's not something that's static, and that, all major insurance companies that I've worked with takes this very seriously. But let me get to something that I think is more productive here, and that is, and I think it crosses every person on this panel, and I think it's been borne out by our discussions with our clinical experts, especially a nice interchange that Dr. Siegfried had with me about looking at guidelines from professional societies and looking at the challenge of grading evidence and coming up with real guidelines that have real teeth from an evidence standpoint. And we've gone through a pretty substantial review of this with our scientific experts, but it seems like what we should be talking about is more specific, explicit biometrics, knowing that there's still subjective aspects of this treatment, because I get a sense from what you both told me that in practice it's all over the map and maybe non-existent in many places, especially if it's not in a dermatology office. So that we get more consistent and as precise as we can with measuring this disease in a standard way, because I think it helps folks like Dr. Fisher, but I also think the pharmaceutical companies should pay more attention to supporting this. So, and I think in the end it should be patient-centered. It shouldn't be based upon just what a dermatologist thinks is important, and I'm being a little unfair to you, but, or what the policy people say. It should be combined. And in the end, I think the thing that's coming out of this for me that I never spent any time with is this question about sort of like it's similar to heart failure. Are we really talking about one disease here? Or is this sort of like heart failure with many causes? And my sense is, especially since we have a lot of unanswered scientific questions around comorbidity interactions, we didn't even mention celiac, right, which is a big deal, and the fact that there's now different lines of interleukin categories, right, to think about this disease, that we're just, no offense, just on the surface of it, right?
Scratching the surface.
Scratching the surface, thank you. No pun intended.
And so I think there's a lot more that needs to go into this from the standpoint of helping to really try to solve what I think may be multiple problems as opposed to one. But I would get back to the precision challenge around the biometrics and the precision of the assessment of diseases being something that I think is a big gap right now.
Don, let me just take that with a friendly amendment, because I think we had highlighted before the difficulty with having, as I think you pointed out, different outcome measures through time makes it very difficult to compare these different possibilities. So standardization of outcome measures that include clear, patient-centered outcomes, but that can be really, going forward, standardized would be extremely helpful. if I were going to turn that into the coverage policy part of this, we've talked about failure of what to qualify for dupilumab and for, Eucrisa or Eucrisa, maybe, if we're trying to figure out different ways to pronounce things. What about the moderate to severe? Let me start with that. Should that be defined solely by failure to, respond to, other treatments? Or is there an easy score or some other kind of way that an insurer should try to create a policy to get us down again from the 18 million to the patients who need this? What should that look like from an insurance policy perspective, the moderate to severe definition, the line that they draw? Do you guys want to suggest how you've done it so far? Because you just said the words, moderate to severe. Is that all you've got? Do you have any?
It's a clinical judgment.
It's a clinical judgment.
It's a
Do you guys have
clinical
anything
judgment.
more than that or not?
No, I mean, we had a lot of internal discussion on that, because that's the one piece that payers are particularly paying attention to with dupilumab, is that, and the ICER data shows it, that on the moderate side, it still has a clear cost-benefit ratio. On the severe side, most certainly does. It's really, really clear. But over time, we know that as the drug is launched, we're going to see a glut of prescriptions, mostly coming from specialists, patients who have been waiting for this drug. And so you see a lot of very good use right away. But then over time, people become more comfortable with the drug. There's more doctors who maybe didn't want to prescribe it initially because they didn't understand it, begin to get a little bit more open to doing that. And you'll see the utilization begin to shift in terms of the patients receiving it. And so right now, we've left the question up just as simply that. Does the patient have moderate to severe atopic dermatitis? We allow the clinician to answer that. We're not using scores or other measures to try to define that. But that was discussed because there is concern that the utilization will go all over the place, still on topic for atopic dermatitis, but maybe for patients who haven't tried topicals or could try them or weren't adherent to them, et cetera. So right now, it's just the question. But that was a very big discussion point.
And David, I know that in your discussions with payers, when you came in...
We were in these discussions.
Yeah,
Maybe the
go
one
ahead.
slight addition to that, which is why, again, what we supported 100%, and I think our part of these criteria is you have to be a specialist. In other words, if you're going to leave it to clinical judgment, you have to leave it to somebody who's seen these patients, who knows what moderate to severe looks like in their own mind. And I go back to the plea of, how do we create a system where the doctor can be the doctor, right? If you're fortunate enough to get in to see one, back to Ryan's point, which I'm fully sympathetic to, if you can get in to see it, do you get a good, outcome there? And on stopping rules, I'm going to just go back and add one point of that. As a manufacturer, I'm fully supportive of stopping rules. Now, why? And the reason I'm fully supportive of stopping rules is that having somebody, the physician, go back after a certain period of time and say, is this working? That's a good thing. Because there will be patients out there who are misdiagnosed. There will be patients who are, and that is the worst thing. Now, what I'm expecting to happen there is, what I don't want to do is have a stopping rule that says, if you didn't get 76% improvement, sorry, you're off. You got 74, just missed, sorry. That's not the world we want to live in, right? But I want to live in a world that says, black and white, you're not working, you shouldn't be on the drug, there might be something else going on. Let's continue the workup.
So let me push a question similar to that, though, that we've raised with oncology treatments a lot, which is, it's a little bit different there, but there are different treatments where people want to experiment with a holiday, a drug holiday, to see if patients really do need to keep taking it every month for the rest of their life. It's very unlikely that drug companies are going to want to sponsor that research. When can you stop our drug? It's just pretty hard to imagine that as a major post.
So we've had
post-approval
interruptions
trial.
in the clinical development, Jonathan, and Elaine could probably speak to it.
So for a payer, again, I just want to suggest, maybe sometimes as a devil's advocate or just to toss it up there, would a payer be crazy to say after a year of dupilumab, it's working great, patients should take a holiday to see if they continue to need it with reassessment if symptoms recur? Is that crazy?
As a blanket rule, that's crazy.
Yes, absolutely. I mean, there's ways of doing it, and it'll be data-driven, it'll be evidence-based. There are studies that have been done, and they're rolling out all the post-hoc analyses and the data as they come, but there are studies that have looked at start, stop, start, stop. It's a very risky proposition for a biologic to recommend a drug holiday universally, keep them off it 4 months, only for them to have to go back on it because they may lose efficacy, they may develop immunogenicity issues.
Do we have any data that that's the case with dupilumab? It's a new mechanism
Again,
of action.
we're going to have more data coming, but I think the smarter and more rational approach is we have some data that's already been presented at conferences. It'll hit the publication realm soon enough, looking at spacing out the dosing, tapering doses, going from Q2 weeks to Q4 weeks. That is the more rational way of doing it, and that's what I would plan on doing. Patient is clear for 3 months, 6 months. We're thinking maybe they're out of the woods for a while. I wouldn't stop cold turkey. That would be a disaster, potentially. Taper it out. The body, it's a very symptomatic disease. It'll declare itself very clearly, and if they start flaring up again, you have your answer. And you can periodically revisit that, but to set up an approach that says, no, you must go and stop right now, I mean, you know, it takes sometimes 3 to 4 years to get these patients clear. All right, for even with, you know, you talk about cyclosporin, years, sometimes to get them to the point
Dupilumab
to clear.
seems remarkably different in that sense.
Well, but still, those chronic lesions will take time. So now you get them clear after months, sometimes a full year.
Right.
Now they may flare up in 2 weeks and go literally right back to where they were at the beginning, and you have to do another year of getting them clear again. And there's some real questions about that. So I think as long as it's a reasonable, rational approach, I think that's okay. But to say stop, I get nervous about that.
Okay.
Can I highlight one?
Yes, and then
the
I'm
one,
going to show you.
sorry, the one death up there on asthma death in the trial, interestingly enough, unfortunately, that was a patient who was being treated for AD who had asthma, whose asthma got better, so they stopped their asthma meds. They came off their AD treatment, but they didn't go back on their asthma meds, and then they had a life-threatening asthma attack. So it's back to just being careful. There's so much we don't know in this setting that scientifically, it's a perfectly reasonable question. How you do it?
All right, thank you. Harold, I'm sorry for the long wait.
No, that's fine.
Can you just pull that microphone again? No, you don't have to. Just pull it closer too.
It's not on.
No, you don't have
Oh,
to
it is?
press
Oh, okay. As I'm listening to this conversation, it seems to me there's a pretty reasonable probability that this thing gets rolled out. You expect to have 350,000 patients on there, but you end up with 600,000 on there, and all of those 600,000 are basically benefiting from the drug. I mean, maybe they're not benefiting as much as the stories that we're hearing today, but every patient is on it for a pretty reasonable justification. How does the conversation, I'm curious how Jeremy and Marcia and David would think about, how would the conversation be different if basically the overall use and expenditures for this drug turns out to be higher than we are predicting right now? You know, Facebook groups start picking it up, patients just like the drug, it's doing great, but it's very, very expensive. How would play out for me how you would deal with that scenario where it just turns out to be an $18 billion drug rather than a $9 billion drug?
Look at their asthma
No,
expenditures.
we would, this is a conversation, you know, one of the things Jeremy highlighted and, you know, which has been very good. We've had different discussions around this drug than I've had previously in this. So we will monitor this as we go forward, number one. Number two is 9 billion is the math. You know, 1 to 2 billion might be an optimistic projection here for this drug. So let's see where it goes. Now, if in fact, which would be ideal, if in fact there's truly 1 million patients out there who need access to the drug and they can, you know, get in to see a doctor, and we do have compassionate use programs, and so patients who aren't in the system, now they still have to get to a doctor, right? But if they can get to a doctor, we will take care of them. So anyway, so these are the elements. Then we have a conversation. Nobody needs an $18 billion drug. I realize there's a couple out there, but I'm just saying that's not how this system was designed to work. It's just, nobody wins in that. That's a short-term, you know, scenario. It's not sustainable. And we're all highly interested in having a sustainable solution here. Now, we can debate about where those levels are. That's fair enough. But we can agree that sustainability has to be the goal. So the point is, we'd have the discussion, and at that level, the price would come down. I mean, you know, and how that happens, but it's not like it happens overnight in this disease, right? It's not quite the hepatitis C, you know, factor where it's going to hit in that kind of magnitude overnight.
Yeah.
I want to take us back. Oh, sorry, Jeremy.
I was just going to add to that. I mean, what we would normally do if we saw utilization that was well above what we were anticipating, we would take a look at the data. We would take a look at what types of patients and prescribers are requesting the therapy, what therapies have they already tried and failed. We would look, because if it's all appropriate use, then it's appropriate. And then, like he said, we would get in that discussion about the utilization is much higher than we anticipated. What about the pricing of the drug? And we have those conversations. Now, if we looked at the reviews and we found out that it's being used in a way that is off-label or isn't supported by the evidence, then we would have to look at our policy and say, okay, did we write a policy that allows access to the patients that will benefit, but has also opened the door into uses that it's not yet indicated for, doesn't have the evidence behind it? And one of the things that we're watching for is honestly once weekly dosing, because we know that was studied. So we know a lot of clinicians are familiar with that dosing. So now that it's going to be prescribed more widely, will they understand that the once weekly and twice weekly didn't really show much of a difference when you took all the data in aggregate? So that's one thing we'll have to watch for, because maybe utilization is much higher than we anticipated, but it's not the number of patients, it's the number of doses per month or something like that.
And just to add, there's a cost per quality type calculation that around this table a lot of us like to talk about. Of course, there's a lot of utilization that is appropriate from the point of view of the patient and the clinician, that it happens to be very cost ineffective in terms of some metric that I would apply in a homework assignment for my students. But it seems to me that's where a lot of the real dilemmas often come in. I think a lot of the use that will not be an appropriate use, but it may be use that is not particularly cost-effective from a systemic perspective, and that's a challenge.
Yeah. So I'm going to take us back in a second to re-hammer in on two issues. Looking towards the future, even if not now, if we considered that insurance is going to have to set up some criteria for severity to make it appropriate to use this, and or some criteria for failing something before getting access to it. I want to try to get more specific about some of those, even how we might determine how failure of even calcineurin inhibitors or topical steroids would be defined from an insurance perspective. Because we know that we can use words like failure of a trial of blank, but a lot of the magic is in how it's actually detailed and how it's documented, because that can either make it easy, hard, clear, not clear. But I know there were other comments that Eric and Ryan wanted to.
I think maybe my questions or guidance, to the panel, kind of plays off of that particular point. So this has been a fascinating case to work on as a panelist, and I appreciate all the amazing work that the ICER team has put into your comments. There's two things that I think, from a policy perspective, I think are important for the panelists and the leaders that are in this room to fully consider. To the clinicians, y'all have a problem with the way you measure and define and classify this condition. And, to say that medicine is an art, which it is, but we also say it's a science. And I also fundamentally believe that you can classify the different types of conditions that exist within atopic dermatitis. And it's possible, and I think that, without a big clinical trial, there's a lot of work that could be done by the dermatology community to listen to the patients and to let their voices and the way that they define their disease be the way that you classify this particular condition. So the trials are based off of, investigator-driven definitions, not those that come from the patients. And I think that would be a really powerful research that doesn't involve billions of dollars of head-to-head trials, but would certainly inform the way we classify this condition over time. And then I think secondly, to the patient advocacy community, prior authorization will be here, right? It exists in this particular category because it's an expensive drug. And we've learned over time, I can't believe I'm going to say this, right, that left uncontrolled, the medical community will use and prescribe very expensive therapies in inappropriate ways. It just happens, and I don't consider it fraudulent, but in a world of scarce resources, things like prior authorization will exist and will continue to exist. The role of our advocacy community is really to figure out how to make that work, right? It's not that it's going to go away, but how do you make it work so that the resources that are available can be maximized for the most number of patients at the price point that you're working in. And so I kind of just, as reflecting on sort of what we've been through today, these are two areas that I think are particularly, gaps, from a policy perspective that I think the leaders there are leaders in this room who can affect both of those. And I just hope that a year from now we're in a different position on both of those topics.
Thank you
And
very much.
I've been waiting to comment on that, because for the record, we are all working on that. We recognize that we don't have good biomarkers and we don't have good definitions, and we've been working, I personally have been working for about 10 years, but 2 years very focused on creating a guidance document for industry and moving forward so that we have comparable endpoints and details about the study, because even though, you know, you could do this on smaller money, we're going to have investment, and if we have investment, we want to have the investment right. And we're going to couple that with guidelines of care so that clinicians will be able to assess patients, and, you know, with the MR. We're doing lots of work on moving forward with that.
Meg, did you want to?
Yeah, so as a patient and a user of insurance, and having been actually uninsured for portions of my life, I know what it is to treat a urinary tract infection on a holiday in an emergency room, and what paying that off looks like in the billing end. So, like, this is mind-blowing to me, this kind of conversation. This is the clearest picture that I've ever had of how each area in the medical industry kind of hits each other. And that's a shame. And I say that being someone who, when being pregnant was the best medical care I've ever received in my life. And not only that, when I got a nosebleed, I could go on the Mayo Clinic's website, and every step was listed. The moment I was done with my child, I was a medical mystery again. And my immune system was a medical mystery. And I would look for studies, and I would look on the Mayo Clinic's website, and I would look on the Cleveland Clinic's website. And I'm someone who, you know, I feel like art is often based on like these early modernist theories, of which when you first start reading them, you need a dictionary in the theory book. In a lot of ways that I feel like when you read a medical journal, you need a dictionary and a medical dictionary and some other things. And I don't mind doing that research. It's not available to me. And the information that the insurance company is kind of giving up about this information is also not available to me. Like, I don't know that I need a doctor to run something by my insurance in a certain way, and that these are the markers of treatment and things like that. And I work in an aesthetic field where everyone has a different idea of what the color red is. In much the same way that, you know, my presentation of atopic dermatitis didn't look so different from those pictures, but it treated very differently. So in some way, shape, or form, it would be nice to have, as a patient, to be able to get into some of this information much more clearly from the community.
Good. Thank you.
I think those lines of communication are improving. I mean, a lot of our patients and members don't know. I mean, the very thing that you're looking for, if you're an Anthem member, you go on to anthem.com under your state, and actually if you put in under a search, you can figure out whether your medication needs a prior authorization or not. And I know that's not your job, but at the same time, if you wanted to know, it's available to you.
Right, but I have to know that I need that medication first, and that's where the rest of the medical studies and the understanding of what that medication is and what those prior authorizations are. It's a much more tiered system.
And that same information is accessible by your provider and your doctor as well.
Well, let me turn this to a certain extent, because I know we want to come around to Ryan, but it triggers in me a thought that, let's assume that there's a lot of patients in this country. We've talked about this before. I'll say it again, 18 million. They've never had a treatment like this, right, for atopic dermatitis. Most of them know it's some cream or other, right? If they've been to the doctor, it's been some cream or other. Now they hear about this new drug from somewhere. Is it going to be a friend, a colleague, a doctor? Will it be a direct-to-consumer advertisement? And someone's going to tell them for the first time whether they're an appropriate patient to consider this option. Given that we've been talking about trying to target, especially dupilumab, from moderate to severe, how is the manufacturer, for instance, considering this in its direct-to-consumer and even its clinician detailing to make sure, if you will, that, as you said, you don't want patients who don't need this drug to consider it to be the right drug for them? What steps are you taking to communicate with the future very big potential patient population?
Yeah, I mean, it's a challenge. So there's been a debate internally. So one belief on the part of specialists we talk to is that there are many patients who are outside the system, who are lost, who may not know that Dupilumab. Now, in today's world with social networks and the like, that's less likely than before, but very possible. And so do you go direct to consumer? Not to sell your drug. This isn't about selling a drug, but to create awareness around, atopic dermatitis and the need to be seen. So we're not doing it. I don't know if we will do it at some point in the future, but I would like I said, for me, you've heard me say it, I'll say it again and again, I want the system to work. I want the doctor to be the doctor. I want this to go through the doctor. I don't want patients going in and saying, doctor, give me Dupilumab, and they, giving it to them because that ask happened, and a part of our system works that way, right? I mean, I want them to go in and say, I have atopic dermatitis, or be told they have atopic dermatitis, get maxed out on steroids and topical steroids, and then say, okay, I'm a candidate. That's it. We'll call what we're calling on specialists because they're the team, the group that's going to be at the point here. So it's no more than that. It's just hard work in the sense of you do the legwork and try to help support the community.
All right, maybe we'll come back to. Well, go ahead if you have a.
Do you, David mentioned that, if this drug, sells to 1 million patients rather than 300,000, that discussions would be had to perhaps decrease the cost of the drug, which is amazing. Has any drug ever had a system to actually do that where that would be something that would be important, I think. I mean, there is always this issue about, making that profit so that you can reinvest it into new drug development, and, you got to sort of temper those things, but having some sort of guidelines about that would be wonderful.
So one of the advantages of a dysfunctional healthcare system is, and with poor access, is that it gives us enough time as a field to improve the management of the disease. When you look at psoriasis, which is a pretty good analog, with the advent of the biologics, the treatment of moderate to severe disease didn't get better. It didn't just get better. Everything got better. The use of topical agents got better. The management of the disease overall increased.
Guidelines more solid.
Exactly. Everything about the management of the disease, our knowledge of the disease, and this is something that David was mentioning earlier, the research just skyrocketed into understanding everything about the disease, proper management, proper measurement, clinical practice, and that's going to happen here as well. So I think early on, you'll get the patients who are the worst of the worst who are going to get on it who need it. I'm less worried about that sort of off-label use or the going out to folks who are milder, because I think at that point in time, our guidelines will actually catch up. You're going to have other societies that are going to really, we're working literally night and day from multiple directions to try to get the management better on the topical side. How do you optimize topical management? Things like that. And it's happening. And, we have, that's going to be a big advantage where by the time we get there, we'll actually be able to hopefully curb it to the correct patients.
All right, so we'll come back to that links into the failure and how you're going to be part of the discussion around how you define what appropriate trial of fill in the blank is before an insurance company would feed in. Ryan, I'm sorry again, it's been a while since you've had your card.
No, that's if you have a question related to this, then I will I wanted to make sure that before we ended, there was some discussion of atopic on children.
Oh, absolutely. I was going to ask a specific question
Okay.
about that too. Okay, so this has been all fun and well. Let's write an insurance coverage policy just for the heck of it, or at least the parameters of one. Okay, again, severity of disease, moderate to severe. An insurer wants to be more specific. Do they use the EASY score, the BSA score, something else? Give me something more than moderate to severe to help be clearer in saying which patients should and should not receive coverage for Dupilumab. What does it look like?
Can we have a choice of any of the three? And I mean in all seriousness.
Just make it up, but it has to be something that the insurers can say, oh yeah, I can administer that.
The problem is they all, we're just barely caught up in the world of clinical trials and selecting what are optimal measures.
Don't give me problems, give me a coverage policy.
I mean, so I think there has to be a recognition that no one measure can do it. So if you're willing to accept 3 or 4 different measures and using the cutoffs perhaps used in the trials.
Boolean and/or kind of things?
Yeah, to me that, because like for example, an EASI of 16.
Yes.
EASI of 16 is a little bit closer to severe than moderate, and there may be patients who may fall below that who really need the drug badly because of the quality of life and the itch and other aspects.
Mm-hmm.
You know, you may not have the full BSA, but you'd meet the IGA score or something like that. So I don't like picking a winner of one outcome when none of them have demonstrated validity in clinical practice.
Understood.
But I could at least accept if you use the full complement, where we have, you know, if they meet the definition of severity by any of the 3 that are used, that at least I think is somewhat rational.
Okay. Can I assume that the insurers would love it if the clinical expert community came up with a criteria list for defining moderate to severe that you could administer as part of an insurance policy?
That's a softball question. Yes, we definitely, definitely would. But to your point, I know at Express Scripts we have multiple policies where a disease state isn't clearly defined one specific way. So typically we would incorporate into that, to that point, multiple measurements. So if you say no to one, it doesn't like deny access. It goes to the next test or the next score, the next whatever. Now, if you say no to all of them, okay, now you're saying they're not moderate to severe. But normally we would try to incorporate more than one when there's not a clearly defined way to measure that disease state.
Okay. Now I'm going to be ruthless with the time left. So for Eucrisa, we don't need to worry about this because mild to moderate essentially means any kiddo with atopic dermatitis. So now we're going to move into the failed something in order to get access. So let's start with Eucrisa again. What would a insurance, maybe you've already got the language, what does failure, is it just a doctor saying it failed, or do you have must try 3 months of a high potency steroid with documented X, Y, or Z? How are you implementing some kind of failure approach to Eucrisa first?
Our medical policy for dupilumab is more specific in that regard, but for our prior authorization for Eucrisa, it is at least one.
At least one.
At least one topical corticosteroid.
And calcineurin inhibitor is part of that or not?
Well, that could be offered as an alternative if
Okay.
there was a contraindication or a history of a reason why someone could not take a topical corticosteroid.
So how do you guys think again about this kind of, we'll start with you, Chris, I guess, just in terms of how do you think about the evidence suggesting what the failure algorithm should look like?
So with Eucrisa, we also do a single step through one topical corticosteroid.
Okay.
Now, we would exclude that requirement if the treatment requires a sensitive area, a place where a topical steroid is not appropriate to be used, so there's more risk of adverse effects, so then we would use that as an exception. But with something Eucrisa, we wouldn't probably go deeper into, like, say, documentation or anything additional to that.
Okay. So we've covered the failure part of dupilumab a little bit already. You laid out the ones that you're currently using. Remind me what you had said about Express Scripts. You guys are not requiring a systemic therapy, but
Yes.
Again, it's a failure of just one topical?
Correct. We would ask about the use of a topical prior to moving to dupilumab. And then we would use that, again, we would shift between a topical corticosteroid to a calcineurin inhibitor if, say, you said the treatment was involving sensitive areas. So we know you might not have used a topical steroid, but you probably have tried a calcineurin inhibitor.
Okay. And does trial mean 3 months, 6 months, just one prescription? What
We
does
don't have duration of therapy in our prior auth or our medical policy.
Yeah, and we don't require anything that long to the point, again, with being a topical steroid, we would usually look for 28 days, nothing more than that.
Okay. Quick reaction from the clinical experts? Again, sound reasonable? Would you create a failure algorithm that looks distinctly different from that?
That sounds like a generous policy. It's not my experience that that's what the policy has been.
Yeah, I'm a little surprised too,
Yeah.
just to be honest, because we know steroids range in potency from here to here, and with a very expensive drug as the kind of get to, hydrocortisone 1% for a month, is that really all you would ask them to do before they qualify?
Dupilumab, it's moderate, at least a
Moderate
moderate
strength.
potency.
Okay.
Yeah.
Right, we also define the potency within our policy for dupilumab as well.
Okay. And David, just circling back real quickly to you, you guys, your team went out to talk to major payers, again, to talk about that combination of pricing and access, and you worked together with them. This is kind of what you're hearing, again, is that some insurers are still going to have some failure algorithms that will include systemic therapy. What's your broader view on how you're thinking about the evidence and the pricing and your discussions with payers should factor into these kinds of
I mean, we
policies?
talk to many or most. I mean, we work to get to an Express Scripts world that fits the ideal as you've heard me describe it. There are multiple who have, more severe criteria, and I think, it is what it is, right? Over time, the data will play out. This is a drug where I firmly believe it'll get stronger, and, I would hope and expect. I think, I hope that everybody in this equation doesn't lose sight of some of the stories here. It's one thing, to be deferred on therapy for a disease where, it's okay to take 6 months to get in to see your doctor. It's another thing to have your script written when you've got this intense itch. It's like having unremitting pain and somebody telling you, I can give you relief, but just got to wait till you get through the process, which, by the way, is probably only take about 6 months, and then appeals and the like. So it's just a very different world. So I do think, these policies will be revisited based on data and experience. So.
But did you sense, because what was in the public domain, so I'm kind of giving you a soft pitch, did you sense that in your coming to them with a price that you felt was pitched low with the alignment with value? Well,
this
by
is an
low,
expensive
I mean,
drug. Let's be clear.
Right,
I mean, it's an expensive drug.
Oh, no, absolutely.
But it was pitched at a level that...
What's been in the public domain have been comments from some payers saying, we felt like they could have asked for more. In the current landscape of American drug pricing, a drug for a condition that is really no competition, it's a biologic. In psoriasis, these drugs are $50,000 to $60,000 a year. This comes in the 30s. So did you feel like that conversation with payers was achieving better access for patients,
Massively.
given your approach to pricing?
Massively.
Are you at liberty to give a general example or a specific one of how that conversation?
I think the Express Script, that's the poster child for the moment here, right? I mean, if you're a physician, there are drugs out there with, I don't know how thick the attestation form is that you have to fill out. And you're in busy practices, and Jonathan Lane can talk to that for sure. I mean, being a physician today is not a fun job. And the reason these things work is not necessarily because the medical criteria is severe, it's because this pure hurdle of having to navigate that is a barrier. And so people give up, or they quit early, even though they would have made it through if they could have, stuck with it, So that's not where we want to get our health care, back to dysfunctional health care. And we all own that, right? And on the pricing piece, just again, put this in perspective, what we own the most of are the year-on-year increases without increasing value. And so as an industry, that has done us enormous damage. It's going to stop. Now, I hope it stops because we self-regulate, not because we get regulated. That will be horrible. But I think one way or the other, it's going to stop. Now, it means that pricing your drug, when you set the initial price, becomes incredibly important that you get that right. And so it's that balance between, I have to get my return, realizing I will not be taking significant price increases, beyond sort of CPI kind of things. But I want it to be accessible.
Right. So those were my easy questions for you. You ready for two not so easy ones? All right. So the use comes in at 600,000, and even the clinical experts are feeling like, wow, this is a lot of patients we're treating with an expensive drug. Would the dynamics of the current market, investor relations, et cetera, ever allow a company to come to them and say, we need to lower the price because too many patients are using our drug?
Yeah, so again, every executive...
So I told you it was a harder question.
No, it is harder in the sense that every executive will give you a different answer, and until you're sitting in that chair, it's difficult. The challenge for the publicly traded company with shareholders is that your shareholders are looking for growth. And so when you take your price down by 10%, you've immediately cut your growth by 10%. You have to make it up by volume. So if you take a huge price decrease, it's very difficult to manage that. So the way I would envision this happening is that as new indications come on, let's look at that. As we get a better sense of the volumes, look at that. But then that would be a gradual adjustment where you get to make adjustment here, you have the volume, and so you keep everybody happy. For better or worse, the executive is not free to just do whatever they want, right? I mean, the owner of the company is the shareholder. They have to balance. The patient is in need of a treatment. The physician, is trying to manage, do the best they can for the patient. I mean, everybody's trying to fulfill their responsibility in this world.
Understood.
It's all got to work.
Understood. One last not easy question. So you talked about the inelasticity of the price and demand curve. And basically, if you could lower your price or raise your price, it might not actually change that much how the drug is used. So when we talk about conceptually the potential tension between long-term value and short-term affordability, we want to make sure we identify that there are different ways to manage that tension. One is to really get out there and find the waste in the system, right, and get rid of it so we can make headroom for that innovation. Another is to figure out a different way to pay for something over a longer term, perhaps. Another way is to prioritize the patients. More like hepatitis C clearly ended up trying to prioritize patients, at least as part of the strategy. And another one is to lower the price. So we are talking again, as someone pointed out, about 1 in 6 of the patients who are 1 in 10 of all patients with atopic dermatitis. We wish that more could get this drug. If you had priced it at $15,000 a year, how many more patients would have been able to reach it? Do you think you're getting the most you can get at $300,000? Would lowering the price do anything to help the healthcare system get this drug to more patients who could benefit?
No, I mean, we can debate this, and I think people, but I'm absolutely convinced looking at this. I mean, the threshold is not 15,000. 5,000 maybe? I mean, there's a point at which, yes, of course, but it's not 15,000. And that's the amazing thing, which is, and we're priced at 37. You come down to 15, that would not change this equation. I think the other thing, just keep in mind, and apologies for the usual, rhetoric from industry, but it's not wrong. 3 trillion, we spend 3 trillion on healthcare. The 14% that we spend on drugs, 450 million, billion or whatever, is an important part of the equation. It hits the pocket of patients, which is part of what, they feel it, which makes it one of the headlines. When I go in the hospital, and I've been in the hospital, I don't feel the pain. It doesn't cost me much. My co-pays are nothing to go in the hospital for thousands of dollars worth of care, but we're not protected in the same way for a drug. So we have some policy structural issues, but in terms of what is truly driving the cost, it's not. Drugs are part of it, but let's keep the proportion inside. And then you take a drug like Dupixent, dupilumab here, and you say, wow, to say that this is a drug that we can't afford when we're not even very good at measuring all of the incremental benefits we talked about, right? I mean, societal costs, the spouse, the productivity issues. I mean, we haven't begun to do justice to the real benefit that this drug is bringing to society. So I just would hate to lose, have a drug like this become victim to some of the other forces here.
Let me just, and I do not know your company. This is more of an industry, because what you said is correct. But if you look at profit margins of hospitals, doctors versus pharmaceutical, there are some players in your industry that are egregious.
Totally agree. And if I look at certain specialties and prices, certain egregious. And the interesting thing about, just so you know, we're so aligned you can't imagine. The challenge, if I'm running a hospital today, if I'm in charge of a hospital, my job is to keep the beds full. That's the irony, right? I mean, we just have distorted incentives here. It's a tough system to work. We can all envision a better world, but it's tough to get there. And I'm totally sympathetic to the head of the hospital, right? He's got to pay his salary, so.
We have often dreamed of a world in which the hospitals are empty and no one's taking drugs and everybody makes more money that way, but it doesn't seem to be easy. I do have to ask one quick follow-up question before we move to final comments. And maybe it's relating to what you were thinking of earlier, but I had written down the likeliness of a 17-year-old, 16-year-old, 15-year-old patient with severe atopic dermatitis really hoping that their clinician can get an exception and get access to it for them. 18, it's such a arbitrary in some way number. So from an insurer perspective, how do you envision, are you just going to basically say, sorry, there's no, the label says 18 and above, we're just not going to look at that kind of situation? What's your process for thinking about how the evidence should feed into looking at people at the margin?
I referred to that a little earlier. If we reach the level of appeals, I think that is the most appropriate place for us to look at medical exceptions. And I spend the majority of my time every day talking to doctors about why this patient was in this trial and saw benefit and why you need to consider to cover this member because. Right. It would almost be unethical not to. So by the time you reach appeals at whatever level that is, either primary or secondary, there are options to approach case-by-case basis,
Yeah.
you know, in consultation with the physician regarding a medical exception.
I'm sure you guys have lots to say, but I'm not going to let you
Can
say
someone
it.
for those of us that are not
Was that close to what you were after?
So, yeah,
'Cause
but for
I thought-
those
go
of
ahead.
us like myself that are not in the weeds of clinical trials, and how do you get, I mean, I'm assuming it's more expensive to do trials with kids and it's more, or maybe it's just more ethical question, but how do you get to a place where you don't, because reading the report and the percentage of kids that are experiencing this condition, I was a little like, well, why did they not include children in the trial of this drug? So I'm just
safety.
background.
It's just safety.
Safety.
You have to start in adults, and then we have 12 to 18, and then we go to the 6 to 12, and those trials are underway, but they have to be layered. And then you get to the 2 to 6 once you've done all the others.
Thank you. Okay.
Got it. All right, I'd like to give each of you a chance for a 30-second closing statement. Oh, apologies, I didn't see that. I hope it fits within 30 seconds, because I also know that David needs to leave for the airport, and I'm going to let him go first in case he needs to sneak out even before the others are done. And then we'll give you a chance for everybody to acknowledge your comments, and then we'll go around for the CEPAC final comments. So anything you'd like to say as a closing statement?
No, I think I've talked enough. I think this was a great dialogue, and appreciate the interest and the questions. Great.
Thank you. Marcia?
It was a pleasure to listen to all sides today. I think on a day-to-day basis, we have so few opportunities to do that. Ultimately, all of us want what's best for patients, members, however you want to refer to it. And we want to make decisions based on medical evidence. And I don't think Anthem takes a different approach than the clinical community.
Thank you. Jeremy?
So this is my first time attending one of these meetings, let alone presenting, so it's been fantastic. I've appreciated the dialogue, and I really just hope that what we've seen happen here, particularly with dupilumab, we see other manufacturers and other drugs getting ready to launch follow suit, because I think it's going to be a much smoother ride for everyone involved, everyone from the manufacturer to the payers to the prescribers and patients, getting access to a drug that's truly going to help them versus what we've seen with some other breakthrough therapies that have come before in other disease states. Hopefully we see more that take this route.
Thank you. Jonathan?
I agree. I think it was a great dialogue, and I think it's a very exciting time for the field. I think it's a very exciting time for patients. For the first time, maybe ever, they actually have hope, and hope is a wonderful thing. So even when they don't respond on dupilumab, they still are hopeful that there's a rich pipeline, and I look forward to the next round of this in atopic dermatitis a few years from now. So.
That's great. Thank you very much. Elaine?
I do have to say that children are still therapeutic orphans, and even though we talked a little bit about step edits, the age cutoff is just something that you can dumb down, and it places a really undue burden on those of us that take care of children. And with this disease, which is primarily a disease of children, it's going to be probably 2021 till we actually see approval, and it's a long time. It's a whole childhood for kids to wait to get a better treatment for this drug. So I think that we are working very hard to define who needs this drug, and if we get that definition, the question is how do we have a dialogue to incorporate those definitions into access. Access is just a big problem, and I hope there can be some more work on that.
Right, thank you. Debbie?
Okay, well, there's been a lot of talk about mild versus moderate and severe, and the need for dupilumab. And I guess I just want to say that for an atopic dermatitis patient, no 2 days look alike. So one day I may look moderate, and the next day I may look really severe. And how I look doesn't necessarily reflect how I really feel. So I would hope that the insurance companies would give the patients some credit and allow us to work with our doctors on that relationship we form to decide what we need.
Thank you very much. Meg?
I can't believe I get the last word. I actually just want to thank everyone for making sure that the patient perspective is here and well represented, because usually that's a 50% shot when you go to the doctor and you actually don't know your doctor, is if you're going to actually be heard. So it's really, really nice that that would be included.
Great. Well, we can't do it without you guys coming and participating, so thank you. For
You're the
being here.
raison d'etre.
So thank you, Julia. You're welcome to stay up there, or those of you who need to leave, but we're going to go around the room, and each CPAC member, starting on this side, I'd like to offer you, and given the time, we should probably try to do a 1-minute closing statement on anything about the process or final takeaways that you'd like to see emphasized in the final report. Bill?
Well, thanks. This is my first CPAC meeting, so wow, like one of the best grad seminars I've ever been in. It was really fabulous. I want to thank the patients. I think their voice is so important to this, the clinicians and the ICER staff. It's very clear there's profound unmet medical need here and significant disease burden on patients. And throughout this process, I was always really trying to listen for that, how that was being accounted for in our modeling, and hearing what the patient voice was telling me and what the clinician voice was telling me, and whether we got it right? And I sort of feel like we did, but I also feel like we haven't fully captured the burden of this disease. It seems so significant, so urgent, but I feel good about what I've learned and what I've heard. It's been fascinating. I took away a lot of learnings today. And then I guess in closing, I just want to say, when I hear prices like I'm hearing, and I think about the vulnerable populations that particularly our foundation tries to serve, and the millions of uninsured patients that are out there, it still concerns me deeply that there are going to be a significant portion of Americans who have this chronic disease that will not benefit from it. Thank you.
Great, thank you. Maureen?
So I actually want to thank the ICER staff for multiple things, and one of them that is very important, not only the dialogue that happens here, but all the effort into presenting some of the pre-meeting dialogues in your report came very clear, and it was really nice to at least hear from some of the advocacy group that they feel their voice was heard. Certainly, this has been a really learning experience for me, although I'm a clinician and treat patients with this condition, not the severe. And I really appreciate the dialogue that happened before. Clearly, this openness about discussion between the insurers and manufacturers is such an important part that hopefully this will serve as a model. I want to thank Dr. Rend and Dr. Zimmerman for presenting a complex topic in a very objective way, in a way that it was very clear. And this really clarifies that we still have a lot of work, and I would really urge our patients and patients advocacy group to cheerlead the process of making it very clear what are the patient-important outcomes that we need to be looking at here in a very systematic way. And now we have methods to develop that, so that will be great to have. Thank you.
All right, thank you. Ryan?
I'll be quick. I mean, ditto what both said before me. And I enjoy these meetings a lot because I think they are an example of being able to have adult conversations. And in my daily life, working in the world of policy and politics, there's a lot of not grown-up conversations that go on. And it's really frustrating. And so it's always good to know that there are smart people on all sides of an issue that can actually sit down and have a conversation, because our health system's a mess, and we've got to start making some changes, and it gives me hope.
Great, thank you. Rachel?
Sure. So this is also my first meeting as an ICER a CPAC member, and I've been in drug pricing for some time, and there are so few places in this country where we can put on a panel, pharmaceutical companies and payers, providers, patients, and hear everyone's perspective and know that everyone is approaching this with a level of good faith, trying to reach the outcome that that works for all parties. And so I just wanted to thank everyone from ICER staff to all of you for helping us with the evidence development generation and for reaching what I think is a pretty good outcome today.
Thank you. Eric.
So again, thank you very much. I think Dr. Mustafa stole my notes, and so I repeat everything that she said and emphasize one more point to the patients that I believe that your voice can define disease severity in this particular case. And we don't have to have the insurance companies or the pharma companies tell us how to classify disease severity, but your voice and your words and what's important to you will be what defines it. And the business model, so to speak, or the financial models will just fall in line with your expectations. I believe that.
Thank you. Jill.
I really have nothing more to add than what y'all have said. You said it perfectly. I appreciate being part of the panel. And I guess the one thing I have to say is I didn't know atopic dermatitis could be so interesting. I had, after you learn multiple myeloma and lung cancer, and I was very surprised. I think this particular subject, for me, we were able to look at, for me, I guess I was just new at it, look at all the different facets. We've always had different, people at the table, but I don't know, the degree to which we got to go into it, I think was easier for me to understand perhaps. But anyway, I appreciate being part of it.
Great, thank you. Scott.
Yeah, thanks again to everybody, and the comments that those before me have stated, I certainly share. The reflections that I have are always related to what I do, and that's teach and educate. And I think in a 6-hour day, the amount of education that took place from the clinical experts, but most importantly from the patients, is just great. And it's something that I've said at other CEPAC meetings, it's something that I always try and instill in those that I teach with. The other thing to the patients, there's the clinical trial side, but there's always the observational research side, and your voices in that aspect are so important as well. Outcomes research is, in this area I don't know that well. We talk about, 1,500 patients in dupilumab and maybe another 1,500 in the crisaborole trials. There's lots of you. There's going to be millions of you out there who are getting this, and we can learn a lot from that as well. But we need your, outcomes perspectives to really make these trials great. So thanks for starting those conversations as well.
Great, thanks. All right.
Ditto to everything. I find what I get out of these forums is the opportunity to get, again, everybody's perspective. And that is amazing because as clinicians, we kind of vilify you guys and you guys because our lives are much more difficult because of the much more difficult landscape, and healthcare is a mess. And there are a lot of people that we see being on the ground who are not getting care, not because they don't have insurance, but because it's very difficult to navigate the PBMs, the insurance companies, and not having clear guidance with poor staging of various diseases. So these forums also highlight holes in the system and give us the opportunity to say, I want to open a dialogue with Anthem and with Express Scripts and make ourselves available to you guys as experts. So it really serves to open up the conversation, and thank you.
Harold.
I'm very grateful to really, of course, first and foremost, the patients providing an opportunity to hear their stories and your stories, but really to all the different stakeholders. I must say, I wish that every conversation that I was in about health policy and health politics was as worthy and as civil as this. Amen. Because they're not most of the time. And people really were wrestling with things that are just inherently difficult. Our system is a mess, but it's a mess in part because there are just a lot of really difficult decisions and choices and trade-offs that are inherent to what we do. And it's not, if it were easy to solve these problems, we would have solved them. They're genuinely hard, and I just was very grateful to be part of the conversation. Thank you. Shimei.
I really like to thank ICER for conducting such a comprehensive review and engaging all the relevant stakeholders to have an open dialogue on such an important public health issue. I hope this dialogue will benefit patients and the society overall. Thank you.
Thank you. I would say the first thing I'm grateful for is our patients who have the courage to come into a room and stand up and tell us your stories and share with us your challenges and your hopeful, sustained success. So I think that's great. I also, every time I come to these meetings, really enjoy the CEPAC. I mean, we become a kind of a tight-knit group, and we're getting better, and we have new solid members too. But I think that the evolution of CEPAC has been great. So that's exciting. Obviously, you know, the folks behind us are great. You know, especially Maggie, who puts together all these logistics with Sonia. You know, so this is really great. Our fearless leader I've known for, you know, 7 or 8 years, Steve, is great too. There's a whole bunch of other people that you haven't met with ICER who are equally as fantastic compared to Dr. Rendon and Dr. Zimmerman. I would say two things that I'm thinking about relative to, so what happens next? Because I think we've sort of now have to answer that question, is I would hope that, and I'm sorry that Dr. Meeker left, that you all just don't go home and wait for the phone to ring from the other points of view in terms of acting. And I would hope too that you'd get to try to sit down more formally together. I mean, the dermatologists aren't going to solve this by themselves, nor are the payers and certainly the PBMs. I mean, you all play a part in solving this problem. And I also mean in specific to David, but also, you know, other manufacturers that you have a lot of resources that could be optimized to help solve this problem. And in particular, I'm thinking about trying to believe in what I'll call the third decade mindset that we need to get to, which is really, you know, I keep thinking about the evolution of biometric technology and sensing devices and the use of data science to look at things like patterns of retinopathy. I don't see why you can't get together with a group that isn't here, the IT group, and come up with a way to kind of move this out of just someone looking at you or looking at the mirror and you know, using it not just to look at your skin, but also how you're feeling, right? I think there's a lot of opportunity to think forward about this, and I do think that's what I hope for. So I just appreciate it and thank everyone for being here. Thank you.
Great. So I too have to start with some thanks again to the patients who've come today and who from the very beginning, as it was noticed or noted, helped ICER really understand atopic dermatitis. As Jill or others said, it would have been far too easy for a science group to go off into a closed room and to have done a study on really bad itchy skin and for a really expensive drug, and who knows what they would have come up with. But we all learned from you, and it really helped frame our consideration of the evidence and of the broader kind of contextual issues and other benefits that have been talked about. I really have to thank, I mean, you guys, thank you for your praise for ICER. I hope you realize that the graciousness and the faith that you bring to the table are what makes CEPAC work. And we're so gracious, I mean, so we're grateful to you because you come, you spend the time reading the reports, you listen with open minds, and you come with, you know, sharp critiques and good questions, but in a vein of also learning and listening right up and through the meeting today. And I think the votes today certainly reflected that. So we do have a couple new members of CEPAC, and you know, new members like new drugs, we have a certain amount of uncertainty about the long-term value, but the early evidence is very strong that you guys are fantastic additions to CEPAC. My thanks also to the scientific team and to Sonia and Maggie and others who helped put on the meeting. The next steps for us are to try to capture this, right? And again, remember that what you heard today is a very important event in American pharmaceutical history. This company did a different thing. They thought differently about their pricing. They thought differently about their conversations with the payer community. They worked with us to a certain extent. But there's change in the air. And I think that patients and others need to hopefully also be part of the movement to demand that change, more transparency, more civil discourse, more thinking about how we all manage, to that hackneyed phrase, our goal, which is sustainable access to the kinds of innovative care that was discussed today. Because we can't, no one party can do it. It has to be a group effort. And it really felt like there was a different dynamic in the way that this was done, that we were very, very proud to have, to a certain extent, be part of, but also to be able to highlight in some of our work and in today's meeting. So we'll capture some of the conversation. It was very rich. We'll do our best. We will also acknowledge that you guys, I asked you some really difficult questions. The payers sometimes think that this is going to be an easy event for them to come to. It's not always. But we are going to try to capture some of the different ways that evidence can be thought of as feeding into an evidence-based and clinically sensitive kind of set of coverage policies. We'll do other things with this as we kind of disseminate the message, but that also will involve those of you in the audience and those of you, listening on the webcast. So thank you to you for being part of the meeting today, and we'll look forward to getting out a final report within the next couple weeks.
Stephen, I have to be sure we leave remembering the quote from Dr. Siegfried that we're just scratching the surface, right?
Thank you, everybody.
So you go back tonight?
7 o'clock.
Good. Oh, you're welcome. Great job.